which there may or may not be. We'll play that by ear. To kick off the event, we are honored to have Dr. Barbara Bass, Dean of the GW School of Medicine and Health Sciences, to provide opening remarks. Dr. Bass is a GW alumna, completing her residency in general surgery in 1986. After completing her fellowship at the Walter Reed Army Institute of Research, Dr. Bass joined the GW faculty as a general surgeon and researcher. Dr. Bass left GW to build the Department of Surgery at Houston Methodist Hospital from the ground up, a great accomplishment. Now again at GW, Dr. Bass leads the academic, clinical, and research missions and provides strategic direction on all aspects of GW's medical enterprise. Welcome, Dr. Bass.
Thank you so much, Dr. Frame. It's really great to be here. Only 30 years missing in that introduction, but that's just fine with me, so not to worry. But great to be here, and thank you. We're so lucky to have Pat Sung with us today, Dr. John Penn. So we're really, it's a great opportunity to participate in this very timely symposium on whole health and wellness. I hope you're all someplace on a beautiful day, right here in our region. Of course, it's bright sunshine and springtime and flowers, and no question, that kind of environment does a lot for one's health, does a lot for one's wellness, does a lot for one's sense of well-being. So, and not everybody has those opportunities to enjoy these beautiful days the way we are right now. So I think this is such a timely focus that this important program has brought to all of us who are often previously focused on exclusively illness and as opposed to that more important and really, as we can say, visionary, probably from a decade or two ago, from the founder of this notion of integrative health and whole person wellness. So we're really, GW is really in the forefront of this field, and I'm proud to be in some way having some engagement in that process. So I hope everyone will have a wonderful visit today. A wonderful symposium. We have incredible speakers that will, that are from founding mothers to national and international leaders in this discipline. And I think the focus that we'll bring to how this applies to all people in our communities is really been highlighted by this last ghastly year as well, as we've seen the differential impact of COVID in many different parts of our communities that have not been well served in the past and remain not well served and with so many structural barriers to health. So I'm delighted to have this incredible group with us today. I know we'll have a most informative symposium. I hope you'll all ask great questions and come away from this resuscitated and motivated for carrying on this important work that I know Dr. Frame and Davidson have already been working on for so many years in our School of Medicine and Health Sciences. So thank you all very much for the opportunity to greet you, and thank you all for the wonderful presentations ahead from our speakers. Have a great symposium. Thank you.
Thank you very much, Dean Bass. And we're all counting on your leadership to move us forward in the field. This is John Penn. I'm honored to be the founder of the Center for Integrative Medicine, going back to 1998. And for the last 4 years, I've been the founding medical director for the Office of Integrative Medicine and Health, supported by Pat and Margaret Sung. So I'm here honored to introduce Dr. Wayne Jonas, who is our first speaker. He is the Executive Director of the Samueli Foundation Integrative Health Program, which is supported by Henry and Susan Samueli to empower patients and doctors by providing solutions that enhance health, prevent disease, and relieve chronic pain. From 2001 to 2016, he was the President and Chief Executive Officer of the Samueli Institute, a nonprofit medical research organization supporting the scientific investigation of healing process in the areas of stress, pain, and resilience. Before that, Dr. Jonas was the director of the Office of Alternative Medicine at the NIH from 1995 to 1999. And prior to that, he served as the director of the Medical Research Fellowship at the Walter Reed Army's Institute of Research. He is a retired lieutenant colonel in the Medical Corps of the United States Army and a fellow of the American Academy of Family Physicians. He is also a board-certified practicing family physician, expert in integrative health and healthcare delivery, and a widely published scientific investigator. He has led and participated in hundreds of research studies, beginning with his time as director of NIH's Office of Alternative Medicine. His research has appeared in peer-reviewed journals such as the Journal of American Medical Association, Nature Magazine, the Journal of Family Practice, the Annals of Internal Medicine, and The Lancet. He has received the 2015 Pioneer Award from the Integrative Healthcare Symposium and the 2007 America's Top Family Doctors Award, and many, many others. So we're fortunate to have Dr. Wayne Jonas, my friend, my colleague, to give you the first talk of the symposium. Dr. Jonas.
Thank you very much, Dr. Pan. It's a great pleasure to be here in this illustrious conference, and it's a great honor to be here speaking with some of the other panel members and some of the other speakers that are here. You certainly have put together a who's who of integrative health research and implementation. So it's wonderful to be here. So I hope I can do you right and kick this off with a talk that I think is relevant for our time, that I just mentioned to you before the speaker was updated yesterday with some new data that has come out. One thing that I think we've all learned is that in the era of COVID, everything changes, sometimes not only daily, but even perhaps by minute and hourly in these areas. So adapting to change is a key feature of this. Let me just check with you to make sure you can hear me okay. And I've just started to share my slides. Is that all right? Everybody hear it?
So good.
And see it?
Yep.
So what I'd like to do is I would like to talk about the concept of healing in the time of COVID, and look at what was going on before that and look at what's going on now, and see, has it changed any? Those are some of my disclosures. I have none. I'm fully supported by the nonprofit, and everything I do is free to the public. You've done my bio. Here's my objectives for the next 40 minutes, is to really understand where healing comes from and how COVID has impacted it. Describe some whole person approaches that can transform how we do care now that COVID has transformed how we need to do care, and then demonstrate some tools that you can put to use on Monday. On Monday, I hope that you will begin to be able to see people more as whole people when you interact with them in the office and in your healthcare setting, that you'll know how to remain a healer in the midst of medical treatment, and you can access some tools that make it easier to do that. So a question that I think every provider needs to ask themselves is, why and how do I facilitate healing and curing? And this seems like a sort of a no-brainer here, but the problem is that what we're trained to do primarily is focused on curing after the person becomes a patient. It is medical-centric, not person-centered. It asks what's the matter, not what matters. And so healing comes from the latter, what matters. And we need now to begin to move to integrate both the person and the patient into our care. If you take this up a notch into healthcare reform and health systems, the question becomes this: how do we get from healthcare to health and well-being? And as we increase the debate and the discussion on policy and healthcare reform and transformation, this is the question that needs to be asked. Not simply how do we provide healthcare as it's done for all, which actually won't impact health very much, but how do we actually transform that system so that it actually creates health? Why do I say this? It's because our current system fundamentally does not produce much health. We are the first in spending in the world, and yet we're 37th by most measures in terms of our health outcomes. 20% of our GNP may be spent on medical care and healthcare costs by 2025, and this is increasing some of the measures and outcomes that we're trying to solve, such as equity and health disparities. Equity is decreasing, health disparities are widening as the costs increase the gap between the haves and the have-nots. All this money is not actually producing health, and there's many, many data sources that have documented this. Here's one of the most comprehensive, done by the National Academy of Medicine several years ago, in which they looked at all of the rich countries in the world, and we're one of those, and traced their health outcomes and costs over a period of almost 30 years. And they found that the United States was declining compared to most countries in many, many important health outcomes, as was our life expectancy. In fact, if you looked at the per capita health expenditures versus life expectancy in the United States, we spend double what almost any other country in the world spends, and yet our life expectancy is somewhere around Czechoslovakia or Portugal, not even considered rich countries. What we're paying for in healthcare is not of value anymore for producing health. We also know why this is the case. Medical treatment, even fully accessed medical treatment, Medicare for all, for example, will only produce about 15 to 20% of health in the population. And that's because health comes from other sources. The two main ones being behavior and lifestyle, and the social and economic determinants of illness. So if we don't get out of the top little black area and into these other areas, medical care will not actually be able to tap into that 80% that actually produces health. To do this, we need a different set of tools. The tools that we have now are focused on curing, but not healing. All of you are aware of the SOAP note, the subjective objective assessment and plan. Its goal is to make a diagnosis. It asks the patient, what's the matter? And then puts it into an assessment with a CPT code and an evidence-based treatment plan that then can get documented in the medical record and get paid for. This is great if, in fact, you need the diagnosis and the treatment, but as I'll illustrate, is not very good for facilitating healing. Healing requires a different set of tools, and I'm going to introduce to you one that I call the HOPE Note. That stands for Healing-Oriented Practices and Environments. And it is a simple approach to explore not just what matters, but more importantly, what is the matter? Not what is the matter, I'm sorry, but what matters to the patient, and getting at their personal determinants of health. It has 4 dimensions. The physical and the external dimension, the behavioral and the lifestyle dimension, the social and emotional dimension, and most importantly, the spiritual and the mental core around what matters for the patient. Let me illustrate how this very practical tool will allow you on Monday to begin to have a different conversation with your patients on their personal determinants of health. This is Joe. He's a typical patient that I've taken care of. Patients like him over the last 30 to 40 years. He was a Navy officer. He had been in the Navy for almost 40 years. Here's his medical history. He was 69 when he came to see me after he had gotten out of the hospital for a myocardial infarction. His father had died of an MI at 75. He stopped smoking at 35 when his dad had his first MI. He then developed hypertension, gained weight after he left the Navy, got type 2 diabetes. He had good medical care. He had full benefits, all access to drugs, primary care, and specialists in these areas. Here is the result of the SOAP notes applied over those years to Joe. For hypertension, he was on 2 medications, elevated cholesterol, a statin, type 2 diabetes, metformin. When he was diagnosed with obesity, he had 1 visit to the dietitian and said, I know more about food than she does, and he never went back. He's now post-myocardial infarction. He's had a stent that maybe saved his life and is on another drug, a beta blocker. He's sent to cardiac rehabilitation, which was basically exercise. He hated exercise. It didn't really work for him. And this is why. Throughout his entire career, Joe was the food guy. He started peeling potatoes on PT boats, 15 people, from scratch. And he watched over his career as food from scratch turned into industrial food delivered on a mass scale in cans and packages. This was known outside the military as fast food. And in fact, the new young service members were used to it and wanted it. He said, Doc, I ate this way too, and I know it has something to do with the conditions that I have. When I sat down with Joe and I asked him what mattered, the first thing he talked about, as so many patients do, is medication management. He was on a lot of medications, a lot of different recommendations. Coordinating that process was a challenge for him. I said, Joe, we have a pharmacologist on our team and I can help you right size your medications. But his main interest was not dying at 75 like his father had done of a myocardial infarction, and now he was at high risk of doing that. He was 69, he had grandkids, he had a good life. He wanted to prevent further disease. He knew that fitness and food were an important part of that. He wasn't that interested in fitness. He loved food, but he knew he had to make some changes in those areas. And he knew his family and friends had to be part of that. His normal routine was to go to the club in the evening, have a hamburger and fries with his buddies, a couple drinks, talk about their medical appointments. The most important thing, though, that came out of Joe's discussion when I asked him what mattered in his life was that since he had retired, he didn't feel like he was really giving back to society. All of his career, he had been defending the country, helping bases and boats and others to function, and now he wasn't doing that. He had, in fact, lost some purpose in his life, and this was the lack of a motivator for make a change for his health. Now, after that, we knew exactly what kind of a team we needed to put together for Joe, and this is what it looked like. A physician who was really just the coordinator of the team, a pharmacologist to help him with the medication, the nutritionist, but the nutritionist now had to have a different role, not just giving him a diet that he should do, but to actually combine that with a chef and a health coach to help him implement it into his life. Fortunately, there was a program outside of the hospital called Healthy Cooking, Healthy Lives. It involved the nutritionist, same one he'd seen inside the hospital, and a chef who he liked a lot, and a health coach to help him put all that together. He knew that he needed to get his family and friends involved. His family was invited to participate, and he knew that he needed to change his mind about how he approached his own health to get his own underlying determinants. Well, after 12 weeks of that program, he came back, he felt better, he lost 5 pounds, and he said to me, why isn't this an ongoing program? Why did I only have to find this out after I had heart disease? And I said, Joe, that's a great idea. Why don't you do something about that? And you could see the little light go on in his head. And suddenly he went back out and he began to coordinate a long-term, year-long class that was open to anybody where he was both the coordinator and the chef of that program. A year later, he had lost 60 pounds. He was off all except one of his high blood pressure medications. He no longer had diabetes, and his risk factors were significantly improved. The likelihood of him dying of heart disease in 75 had been reduced. Most importantly, had found his purpose again in life. And we all know that meaning and purpose is one of the biggest factors for a long and healthy life. This type of approach is a different type of approach than you and I were taught in medical school. We were taught in this top circle, the conventional medical approach. And what we needed to integrate that with non-pharmacological, complementary, and evidence-based components and self-care, behavioral components. and do that all within the context of the social and economic determinants that an individual has. I call this integrative health, not integrative medicine, because it is in fact producing health and getting at those kinds of determinants. That was before COVID. Now came along a little bug which has disrupted the entire culture, the entire world, and our healthcare system also. COVID has in fact permanently impacted primary care physicians. 25% have lost members and have unfulfilled staff roles and have lost income. 48% report mental exhaustion and increased unhappiness in their practice. Family decision makers, those who actually make the decisions for the young and the old in the family, are now reporting more mental health crises, more obesity, more addiction and community violence, and increased racial disparities. Healthcare executives are also feeling the impact. For those in the middle of the storm, ICU and overcapacity has hit. For those who have not been in the middle, revenues have declined. Rural systems are closing, and most places have put quality improvement items and practices on hold. This has affected the entire healthcare system. How has it affected patients? Who dies with COVID? Well, unfortunately, it's the same people who have been dying at higher rates before COVID. That includes the elderly, those with chronic illnesses, people of color, low income, with poor healthcare access, and those in service jobs. In fact, COVID has simply increased the risk of those that were already at risk for dying. COVID has had a huge impact on life expectancy. If it had started to decline a couple years before COVID, it has now been rapidly accelerated. In fact, in a single year, life expectancy in the US has dropped by an entire year. And that is 3 to 4 times in people in color. It's not over when it's over. Just because you've had COVID and gotten over it or think you've gotten over it doesn't mean you've gotten over it. Persistence of symptoms occurs in 1/3 to 1/2 of those, even though those who haven't been in the hospital or had severe disease. And now in a study that just came out about a week ago, they've shown the ubiquity of these symptoms. Many symptoms in multiple organ systems are persisting, even in those that have not had severe COVID. And there is a 60% increased risk of death for non-hospitalized patients who have had COVID. COVID is mimicking and magnifying the chronic disease issue that occurred before COVID. So COVID too needs a whole person approach. In fact, one cannot deal with COVID before or after without looking at the whole person. And that includes the body and the external components, as I've just illustrated, the behavior and lifestyle issues, the social and emotional aspects, not just mental health, but for everybody, and the spiritual and the mental impacts that it is producing at the center of our being. We need to change our thinking. If you need to be put on a respirator with an acute problem, we have a tremendous system to do that. The mechanical mindset, looking at parts of people, saves lives and gets rid of things that have good physical and anatomical causes. However, applying acute care thinking to chronic illness and the whole person not only doesn't work, it's often counterproductive. To manage chronic illness, we need to change our mindset to an ecological mindset that deals with whole people and whole communities and see that in them every time we encounter them. Let me illustrate how this is happening with integrative and whole person care at a practice up in New York that was at the center of the first wave of COVID. This is Alan Roth, chair of the Department of Family Medicine at Jamaica Hospital Medical Center in Queens. Queens is the most diverse city in America. 135 languages have to be translated in Alan Roth's hospital. It cares for over 1 million people, 75% of which are on Medicaid or have no insurance. In 2019, we began to work with Dr. Roth and his system to implement integrative health practices into this safety net hospital. He was beginning to implement some of the tools and many other resources, and I'll show you a few of those in a minute. And along came COVID, and they were at the center of the storm. in the first COVID surge. In fact, they had to convert an entire pediatric hospital into an ICU because of the cases that they were having, 100 deaths a day and more. He has now launched a post-COVID, long COVID clinic and implemented integrative health practices into that. And we'll see how well those perform. But given what I just told you about long COVID, some of those same tools are going to be necessary. Let me illustrate a couple of the tools that we have helped Dr. Roth to develop and developed with him that are available now to anyone who is dealing with the current situation. These tools have focused on avoiding burnout, on enhancing the immune system, and on building resilience. Let me illustrate some of those. Dr. Roth and the Jamaica system had already begun to implement the Hope Note Care Toolkit, which include the personal health inventory, which we adapted from the Veterans Administration that you'll hear about in a minute, I hope, and then a guide for doing an integrative health visit using those tools so that you can have that conversation with patients about what matters and their own determinants of health, and then creating a personal health plan that gets at the 80% of factors that produce health. Supporting that are a number of related resources that Samueli's staff have produced and that we've drawn from around the country, in fact, even around the world, if they're free and available to others. Those tools, interestingly, Dr. Roth has found have been applicable across the healthcare board. Even though we developed them for patients, he has found them, and we've worked with him to help apply them to providers themselves for self-care, stress management, and to improve performance. Patients, of course, to support their healing, build their resilience and immunity, and in the community setting for preventative care and to address things like loneliness and trauma. Let me illustrate just a couple of those. First, by starting at the center of the person, the spiritual and the mental, which is often the answer to the question, what matters to you? Healing the healer, that is addressing burnout, was an important thing before COVID. Here's the National Academy of Medicine study that came out before COVID on the problem with clinician burnout. The American Academy of Family Practice also created those areas. This has gotten worse during COVID. Here's a 2-minute self-assessment that Dr. Roth has applied for his staff to help them apply integrative health principles to their own healthcare. You can take this in 2 minutes and do essentially a health and well-being checkup using all the dimensions of yourself. Here are some resources on preventing preventional burnout in a time of crisis by Amy Locke from the University of Utah. An excellent talk and set of tools there, and I highly recommend it to you all. Mental resilience largely depends on mindset. And this has been shown even before COVID and in return to COVID. I've experienced this and dealt with this a lot in the military for those who have been suffering from moral injury, PTSD, and the trauma of war. The mindset matters. Those who approach stress and trauma with the idea that this is going to make them better, that they're not going to return to normal, but to a new normal, will do much better than those that see it as a negative component. So trying to make it seen as something that can be used to build resilience is one of the most important factors for actually building resilience. How do you do that? There are very simple tools that work and that have been shown in good research. Mind-body practices, simple mind-body practices like mindfulness meditation once a day can enhance and change the mindset. Here's a link to a 15-minute meditation, a gratitude meditation, and breathing exercise that we've produced and is available. Gratitude journaling has been found also to rapidly help with burnout. It's a simple technique that simply means writing down 5 things that you're grateful for every evening in a journal before you go to bed. And even 4 to 6 weeks of that can reduce burnout in those who are facing the kinds of stress and trauma we're talking about. These tools are here available for you at our website. Many, many other resources are there including mind-body resources. We produce pocket guides for that. Imagery by the psychologist Belaruth Naprasak, who has made many of those available free. Other types of things like biofeedback and the meditation that we talked about. Here's a list of free imagery resources, a number of them in Spanish, that the psychologist Belaruth Naprasak has provided free through our website and can be downloaded in those areas. Breathing may, surprisingly, actually improve lung function if it's done properly. This was being studied before COVID, and it would be great to look at it in the process of COVID through deep breathing exercises, Tai Chi and yoga, which improves lung function balance in those areas. Often these things can be done quickly, 5 minutes, 1 to 3 times a day. Here's additional resources. I mentioned the gratitude breathing exercise. There are a number of well-being resources from the Academic Consortium of Integrative Medicine that have been adapted to the current crisis. And then, of course, how to apply good evidence in this area. I highly recommend Tufts University's lecture on evidence-based medicine in the time of COVID. The social and emotional dimension has been important, and not just for those in mental health. Everyone has a social and emotional body, so questions about social support are essential to do whole person care. Loneliness is ubiquitous and has impact on not only mental health, but physical health. We even know the mechanisms for doing that. How do you address loneliness? Your role in your day-to-day practice is to listen and connect, creating a healing presence, and then creating teams that can help facilitate that. Group visits are a great way to access and reduce loneliness. Many of you know Jeff Geller, who's spoken at this conference, Shilpa Saxena, who's demonstrated and has a whole instruction manual for how to operate group visits, including virtual group visits that many of us have now gone to. Here's the AMA's version of that from Thomas Bodenheimer on health coaching and training people, not just in health navigation, getting them to specialists and to their appointments in their pharmacy, but actually facilitating their ability to change lifestyle. These resources have been collected and are available at this link on our website, Healing Patients in the Time of Loneliness and Social Isolation. We are supposed to physically distance, but it shouldn't have been called social distancing because we need to get socially closer and as we physically distant, a difficult thing sometimes to do. The behavioral and the lifestyle dimension also are equally important in this area for facilitating healing. And Americans now realize that even more than ever. Here's a Harris poll that we commissioned asking patients what they were doing for self-care in the pandemic. And there's been a marked increase in effort and work to try to improve healthcare, mind, body, and stress management in those areas. And yet most of them report they're still struggling. They need some help in these areas, and they're looking to their healthcare system and providers to help do that in those areas. So now is the time to step up because there is a readiness within the population to address these kinds of self-care practices. What are those? Well, there's basic self-care kinds of practices that involve the things that you all know, the lifestyle components: smoking, relaxation, sleep, getting out in nature, eating healthier foods, and considering some of the herbal components that might reduce inflammation or help modulate these areas are all things that you can talk about with your patients. There's a growing body of evidence that integrative practices, including supplements and this type of thing, may be useful in these areas. Unfortunately, as in other areas of COVID, this is a new area and the evidence is growing, but not there. Here's a patient I had that came to see me, 64-year-old male with hypertension and obesity, both risk factors for severe COVID. He contracted it, had a fever, cough, fatigue. His O2 sat was pretty good, and his respiratory rates, however, was a bit up. He had collected a whole series of things that he was taking that he hoped would help him during this acute phase. And he wanted to know what's reasonable and evidence-informed that you could actually recommend. Every week, new evidence emerges on these things. And while many of these kinds of nutritional supplements may be useful to enhance health, for example, vitamin D, and reduce the likelihood of getting severe COVID, just like some of the new medications that have come out, most of them don't seem to actually work for the treatment of COVID. And I've listed a number of recent studies that have come out for these, looking at the treatment for this and a number of off-label drugs that are being used in those areas that don't seem to work, or that have to be used under special circumstances with certain types of people and certain types of populations. So how do you use this evidence? Well, we need to up our game in the appropriate evidence-based clinical decision-making during times of COVID, and we need to do it more rapidly than in the past. Here's a guide that I provide to my residents and medical students that I teach. I call it the 5 Ps of evidence-based clinical decision-making. First, protect patients from harm. If they're into things that are going to hurt them, that have direct harm or costing too much, you might want to steer them away from that. Permit what helps, but maybe hasn't been proven yet, but it's not going to harm them. We know that engagement and self-care engage the placebo effect and the meaning effect. And this in itself can help people feel better and get better as long as they're not being harmed. Promote what has proven. Very often things that are off the radar screen, but there's no economic engine to push them, don't get into health practice. But if they're proven, they should be made available, and you should make them part and parcel of what you do with patients. Payment is key. Financial toxicity in this area can be just as harmful as others areas because it can detract people from things that they need where they might spend money more effectively in those areas. Always, always, always partner with the patient. This is about person-centered care, not just evidence-based medicine, and it's the goal of the clinician to merge those two to help the individual patient in front of them the best possible. Finally, the physical body and the external dimension is the one that we focus mostly on, but I hope I've illustrated to you that these other dimensions are equally and sometimes more important in those areas. Certainly keep your body safe and well. If we had been doubling down on preventing and reversing chronic diseases such as high blood pressure, obesity, diabetes, and cardiovascular disease, we would have had much less illness and death during this pandemic, and that will be true for pandemics to come. Follow the CDC guidelines for keeping safe. Get the vaccine, mask, be outside, social distance, and keep surfaces clean. Surprising number of people don't think these are important, but the science says they are. Educate your patients about that. The physical environment can make a big difference, as we all know. Internal spaces, external spaces, where you work and play. And we've produced a set of guides on creating optimal healing environment spaces and how to more safely work in this era of social distancing. For those of you that are designing and redesigning your clinical spaces, I highly recommend this group, Envia and Lori McAllister, that has an expert data-based approach for creating an optimal healing environment. Putting it all together. How do you put all this together? What can providers do to integrate whole person care? Well, first of all, do a whole person care or integrative health visit. And I've pointed to some tools that can help you do that. Add some simple methods that have evidence behind them and that are not harmful that you can use immediately on Monday. That includes new technologies that are free and accessible sometimes that can be delivered to your patients at the point of care. And then finally, redesign your teams, including health coaching, team care, group visits, so that good shared decision-making is a routine part of practice. We have a training kit for preparing for an integrative visit, doing an integrative visit, and then continuing support on that, and it's available online and free. There are ubiquitous or a large number of resources. Here's a partial list of those. And I've shown you some that we've drawn from others, and we point to others that are available and again are easy to access in these areas. These tools are getting uptake around the country. Here's a a network of centers around the country, large and small, that are beginning to implement integrative healthcare with these kinds of simple tools to make it routine and regular. Here is a free CME course for applying integrative approaches for chronic pain and opioid use. Yes, the opioid epidemic has not gone away. If anything, it has gotten worse during the COVID pandemic. So we need to continue to pay attention to these areas. This was developed by Tufts University. You can get AFP prescribed credits and a certificate for that. And again, it is free at this link, integrativepain.com. Our goal, and I hope the goal of everyone, is to make whole person care routine and regular. And I urge you all to begin to do that now. Don't wait until you've had full training and everything. You actually have these resources available at your fingertips in your community if you begin to have these discussions with patients and to design your care teams to deliver them. Start now. Start on Monday. You can make healthcare truly part of creating health and well-being and not simply providing medical treatment as currently occurs. Thank you very much.
So I'm Dr. Andrew Heyman. I'm on faculty at GW. I helped to start the integrative medicine program in 2015, and I have the pleasure of introducing Dr. Tracy Gaudette. I feel like I'm having these flashbacks of, reminders of how long we've all been in the field. And when I was back at University of Michigan in the 90s and remembering Dr. Jonas visiting and saying, wow, what an amazing moment. And then also hearing about this incredible program at University of Arizona with Dr. Gaudette, and my goodness, how we've all sort of moved on. So, it's really a pleasure for me to introduce Tracy after all these years and watching her just explode into a major role in our field and being such a leader. So Dr. Gaudette, in September 2019, Dr. Gaudette began her role as executive director for the Whole Health Institute based in Bentonville, Arkansas. And prior to accepting this position, Dr. Gaudette was the founding executive director of the Veterans Health Administration's National Office of Patient-Centered Care and Cultural Transformation. This office is charged with leading VHA's transformation to whole health, an approach to healthcare that empowers and equips people to take charge of their health and live their life to the fullest. Under her leadership, VA healthcare delivery has been radically re-envisioned and is being implemented nationally. Previous to this, Dr. Gaudette was with Duke University Health System, where she served as the executive director of Duke Integrative Medicine until 2010. And under her leadership, Duke Integrative Medicine created a state-of-the-art healthcare facility dedicated to the transformation of medicine through the exploration, demonstration, and research of new models of patient-centered care. Prior to her work at Duke, Dr. Gaudette was the founding executive director of the University of Arizona program in integrative medicine, leading the design of the country's first comprehensive curriculum in this new field and launching the distant learning fellowship. In addition, Dr. Gaudette co-founded the Consortium of Academic Health Centers for Integrative Medicine. She is board certified in obstetrics and gynecology. She's also a recognized leader in the transformation of healthcare. She speaks nationally in public and professional venues. She was featured on the PBS nationally acclaimed special entitled The New Medicine and named by Shape magazine as one of the 11 women who shaped the world. In July of 2011, Dr. Gaudette was recognized as one of the top 25 women in healthcare in 2011 by Modern Healthcare. In October of 2013, Dr. Gaudette was featured as a game changer in Fortune magazine. She was honored as the 2013 recipient of the Bravewell Leadership Award for significant contributions to advancing the field of medicine. Dr. Gaudette is also the author of Consciously Female, a book on integrative medicine and women's health and body, soul, and baby. So I want to give her a very warm welcome. Thank you so much for joining us today. It's really a privilege to have you here.
Oh, you're awesome. And next time we're going to give you a really micro bio. I'm sorry.
I thought that was the small one.
Well, that's a kind of embarrassing, but thank you so much. And it is really exciting to think and reflect on where we have all been and where we are all going. Let me move my camera a little bit. And I'm guessing you guys are hearing me okay, or somebody would scream up, right? Scream out. Okay, so let me then, and Wayne, it's always dangerous when you give me more time to talk. Let me make sure this is going to work. I need to go to share. I have Jenny, my assistant here, to make sure I'm doing this correctly. All right, so I will go ahead, and I appreciate Wayne's conversation with us, because Wayne, not surprisingly, you created the big case for a lot of what we're going to talk about in a little bit more depth today. So I also included a pretty comprehensive slide deck so that you all can use that and have access to that. Certainly, please take advantage of that and use anything you'd like. So some of what I put in the deck is really for as a resource, and I'll go pretty quickly through that. So I just wanted to say that I'm really grateful to be a part of the conference. The work being done here is amazing. And one of the nice things, of course, about the whole COVID world is we can do these kinds of conferences more easily and share them more broadly. So thank you for allowing me to be a part of it. So the concept of this radical redesign that we're all involved in, I wanted to say, I will say very briefly why, because I think that Wayne did a great job of doing that. But the essence of this, Wayne outlined in terms of bottom line is our current system isn't working, to put it bluntly. And again, I don't need to go into the depths of that, but I think we're all on the same page. The world has changed dramatically. And again, Wayne did a beautiful job of talking about that and the impact of COVID. And really the thing that I would share about that is I think it really does emphasize that we need to not only rethink how we do healthcare, but what is healthcare and what is the purpose of healthcare, and then redesign how we deliver it to get different outcomes. So it's a major, major concept, and we've been working on this for a long time. I think what's different now for us is that, this one of my favorite sayings has always been, you can't have breakthroughs without breakdowns. And now I've modified that to say we can't have major breakthroughs without major breakdowns. And that's what we're in, right? Major breakdowns on many, many levels of society. And it really does create, in my opinion, a great opportunity for change. So let's seize it. It's never easy. So the definition, and you heard this in my intro, that we're kind of using around whole health. People are using the term a lot, which is great. But I think from our perspective, defining what that means with explicitity is important. So the concept that whole health not only treats disease, but really reorients everything to empower and equip people, all right? Both empower people, and we'll talk more about that, and equip people, another core function of the future health system, in my opinion, and two core functions that we don't currently do very well. We're not designed to do that. So empower and equip people for what purpose? For sake of what? So that people can take charge of their health, their physical, their mental, their spiritual health. For what reason? Not just so they don't have diabetes or hypertension, but so that they can live their most full and most meaningful life. So if you think about that for a moment, and you think about that as the paradigm of health care, that's a radical shift. I mean, that's not how we define healthcare right now. It's not the purpose of healthcare right now. So if we're on board for that, it means a lot of things have to change. Not surprisingly, I like to use the concept of as is to will be. And if we look at the future state, if we buy into that, and I'm certainly committed, and my team here in Bentonville is completely committed, as well as the rest of you all, to driving this transformation, a lot of things shift. The entire focus shifts. Yes, we still need to focus on disease management. That's always critical. But does it have to be the sole focus of the system? Or what happens if we shift and broaden and think about the person, and more than just the person, their purpose? And I'll talk more about that in a moment. I'm not going to read this list because I know this is an audience that's on board with this, but I do think it's helpful to see, this is how we're shifting. We're still going to do the current system, but we have to do it bigger and broader in a different way. Yeah, there's never been a greater need for radical transformation than now. And I don't think I need to say more about that on all levels of society, in my opinion. And when you think about what success looks like, I think the first couple of bullets are probably pretty obvious to most people. I mean, certainly if we're successful in we'll see an increased well-being, both physical and mental, and that will be measurable, right? We'll see decreases in pain and obesity and depression and chronic conditions, the things that we track. We should be seeing also corollary an increase in self-care, decrease in costs, needless to say. It's interesting on the employee side, if we're really succeeding in this, we're also going to see an increase in employee engagement and productivity. The last two bullets are the ones I wanted to focus on a bit, because I don't know that they're spoken about that often. And really, truly, the increase in person's sense of meaning and purpose, an increase in the sense of connectivity, compassion, and our collective humanity is, in my opinion, really what this is about. And it's kind of like an, oh, by the way, people's conditions will get better and their costs will go down, et cetera. But it's much, much more profound than just the disease side of it. Ultimately, a transformation in social consciousness is what we will see, and with it, a quantum leap in health and well-being. So the core issue, I've spent my whole career in these kinds of conversations and trying to do things differently. And somewhere around, I don't know, maybe 10 years ago, my own personal aha was, oh my gosh, like the fundamental issue is we are starting from the wrong place. And what I mean by that is that we're starting, and again, I mean, I'm an obstetrician gynecologist. I feel like I was always practicing. I certainly tried to always practice in a holistic way, in a compassionate way. And I think by and large, I was doing that. And I was still, however, starting with the chief complaint and the problem list. And I was making a treatment plan for the problem list. And I realized along the way that, wow, like I'm not actually starting, as Wayne said, with the person and who they are. And I think I love to tell stories, and I'll try not to tell too many because it takes a lot of time, but I think stories are important to illustrate this. And probably one of the more poignant stories I would share about this was actually a story shared to me with the director of the VA in Dallas, Texas, and he was sharing the story of a veteran who had committed suicide on their campus. He was an outpatient in the VA there, and he got great clinical care, and his patient-centered care team knew him well, or they thought they did. He was compliant. He had hypertension and diabetes, and his hypertension was well controlled, and his hemoglobin A1C was where it needed to be, and he was seen regularly. And when this gentleman committed suicide, it really sent a shockwave through the primary care team in a big way, because they're compassionate, caring people. They thought they knew him well, and they didn't know he was suffering. And his family said, oh yeah, he's been struggling for a long time just to get through the day. And that pausing to think about that, and the team who first felt personally responsible, of course, we realized, you know what, it's because we're asking the wrong questions. We're starting from the wrong place. We're dealing with the hypertension, the diabetes, the list of problems, and we're addressing the problems, but what about the person? And we missed his suffering. And that's something, hopefully we don't forget. We actually really need to change the conversation. We need to start from a different place. So I wanted to say a bit more about purpose. And as we've done this work, understanding the power of purpose in someone's life has the opportunity to flip the entire system and change the entire intention of healthcare. So what if we actually help people reconnect with a sense of meaning and purpose in their life? What if we change that conversation? And I will share that I often share that my own personal aha around that was when I was still at Duke Integrative Medicine, and a lot of my patients there were cancer patients. And I started realizing that a lot of those cancer patients were telling me, I'm not even asking the question, they were volunteering to me that their cancer diagnosis and the journey they were on was a blessing. And of course, you first hear that and you go, oh my gosh, like cancer is horrific. And it is. And they weren't saying it wasn't horrific. But what they were saying, person after person, unsolicited by me, they were sharing that the cancer diagnosis made them stop their normal day-to-day life and pause and reflect on, wow, the question that Wayne asked, what really matters, like really matters. If I only have days left, or even if I have decades left, what really matters to me? And then realigning whatever time you have around that which really matters. And I was so touched by that. And I just thought, man, let's not wait for the cancer diagnosis, right? What if healthcare was about asking those questions and helping people reflect on those very things in their life and realigning everything behind their purpose? And so I've been kind of obsessed with that. And I think this is a great study. I don't know if you guys have seen this study. It was published in JAMA in 2019. And it's great, right? Because it's basically, there's been a fair amount of evidence saying that we know that a strong sense of purpose in life leads to improvements in physical health and mental health and quality of life. That's been pretty well documented. This is a great study that takes it one level further. It's about 7,000 patients in this study. And this study showed that life purpose is actually significantly associated with all-cause mortality. So, and in a kind of a dose response curve is what you can see on that slide. And the reference is there if you want to pull the article. So I love that. I love it. It's like, great, evidence, purpose really matters in a very significant way. It's linked to mortality. And that's great to know. So we should be paying more attention to purpose. But the real question I have is, what is the opportunity if we not only help people focus more on their purpose, but we then link purpose, that own person's sense of meaning and purpose, as the driver of their healthcare? What if that becomes the foundation of their healthcare? So everybody on the team, anybody associated with that person, is fully aware of that person's purpose. And I want to say a little moment about this. I have gotten sometimes some, in my opinion, kind of obnoxious feedback on that, saying, well, that's fine for, educated, people who, they think about Maslow's triangle and they think, oh, if you have all your needs met, you can have the privilege of thinking about purpose. And I want to say wrong. I mean, some of the most grounded people I know in purpose have been people that I've known and loved in Haiti, in the poorest country in the Western Hemisphere, who are absolutely grounded. They don't know where the next meal is coming from, and they really may not survive, but they are grounded in a sense of meaning and purpose in their life. And the same is true when we worked with our veteran population and the homeless population. So this is not, a hoity-toity concept. This is like, what brings you a sense of joy? And what is your sense of meaning and purpose? And that, if you're a human being, that's a pertinent question, right? So if we actually link your healthcare to that sense of purpose, so that your healthcare is actually in service of your sense of purpose, that's really profound. And even though it's really profound, I would say it's not enough, right? You can have, I think, exploring a sense of purpose allows people to become intrinsically motivated about their health and their self-care. So that's huge, because the intrinsic motivation is absolutely critical. And we know that just pounding people with data that, oh, smoking causes cancer, or you should lose weight, we all know that. There's this huge gap between knowledge and behavior, and more facts and knowledge does not bridge that gap, right? What bridges the gap is intrinsic motivation, wanting to take on your life, wanting to take on your health. So, but it's not enough. And what do I mean by that? If you don't also have the new skills to address your self-care, if you've only ever eaten one way your whole life or managed your stress one way your whole life, it's not enough, right? So, but if you think about coupling a strong sense of purpose, having that be the foundation of your self-care and your healthcare, and then coupling that with people supporting you and learning new skills and incorporating new skills in your life day to day, now we have a chance to really see magic and hope return. And I will say that that's the theme I keep seeing, is hope. So this is an evolved model. If you've seen, this started at Duke and everybody's got their models. And then we, again, evolved that in the VA, and now in the Whole Health Institute, we have evolved that a little further. And the biggest thing I would say that has evolved is the center I mean, we said, let's say what we mean, my purpose. Let's put that in the center of this paradigm. It starts there. That's where we're changing the conversation. And of course, you can see, and not surprising to anybody in this audience, that the skill of mindfulness, which we're now terming in what it actually is, pause, notice, and make a conscious choice, is important for all areas of self-care. Self-care is the biggest piece of this model, right? We know that. That's really what matters most. Combined with care, with good health care in the context of our communities equals whole health. So that's our paradigm. And I have a couple slides that dive a little bit more in depth on that. I'll get to in a second. So I wanted to just say, when I have reflected on what's really different about whole health, these are just my reflections. I think there's 5 key distinctions, and there's 1,000 ways to split these up. But in the way my mind works, the first is the one I spent most of our time so far talking about, right? Changing the conversation and starting from a different place, starting from that exploration of meaning or aspiration or purpose. The second key distinction, in my opinion, is helping people understand that their self-reflection and their self-awareness of how their body is, how their mind is, making that conscious, that there's a tremendous amount of wisdom in there. And that, yes, the physicians and healthcare teams have a lot to add, but they are not the experts on you, right? So this concept, it's a real shift to say, no, you pause and reflect, and your own self-awareness, in these areas of self-care is absolutely essential and needs to lead the way. That's a shift. The concept of holism, I think this is funny, right? I think the way to think about it is, as physicians and other healthcare providers, we're trained to look at the risk factors and what's the greatest risk factor. Oh, you're a smoker. I'll pick on smoking for a second. Well, let's make that your number one priority, because that's, the biggest barrier to your health and well-being, perhaps. And perhaps logically that's true. But one of the things that's different about this approach is to go where the water is flowing, one of my friends always said, meaning if somebody knows, that they are not going, I'll give you another quick story. There was, actually it's the same Dallas VA, the facility director there told me another great story about this guy. He's like, oh my gosh, he's the facility director, and he's kind of a small guy in stature, the facility director. And he tells a story about a very large, strong, angry veteran demanding to see him, coming into his office, pounding on his table and saying, if one more person tells me to stop smoking, I will never come back. And then he went on to say, with tears, that there are many days where that cigarette is the only thing between him and pulling the trigger on himself. And to not be known and to not be seen as the person he was, struggling with what he was, and somebody, and I'm sure trying to do the best they could, saying, oh, you're a smoker. It says here I should ask you about your smoking and encourage you to quit. Doesn't work, right? And actually risks alienating that person. So the concept of going where people have energy and interest to go, rather than just the linear top down, you should lose weight, you should, stop smoking, is a big shift compared to the way I was trained anyway. The fourth of these is the innate capacity to heal. And everybody again on this line, I'm sure, sees it that way, but to recognize that that's not the paradigm of the medical model. Obviously, the medical model is find the problem and fix it. It's a war. That's why we use language around, everything's an anti. We have an antibiotic, an antihypertensive, an antipsychotic, because our paradigm is, here's the enemy and we're going to go to war and fight it. Very different paradigm to say, actually, the body and the mind have innate capacities to heal. They're not limitless. It's not like if you do it all right, you never get sick or you never die. But, and we have seen this in COVID, right? We've seen this a lot, that if your intrinsic capacity to heal is as resilient and strong as it can be, the things you're at risk for are less likely to happen or less likely to be severe. So it's a flip in the way we think about approaching health and well-being and disease management. And lastly, the fifth one, in my opinion, is actually the power of experience. And the reason I want to emphasize that is that creates the passion. We can talk about this all we want, but unless you or your people or your employees have a personal experience of whole health, Nothing else matters. The rest is just concepts, and it's not going to get you where you want to go. So from my vantage point, this is the way I think about what makes whole health and this approach so dramatically different. Okay, so having said that, the question is, okay, all right, let's just say we're up for that. How the heck do you design a system to do that? And I will reference a lot of the VA work in this section because I feel like the VA has done about 8 years of very intensive R&D on this very question, having been the big health system. And the VA said, we want to do this. So let's figure out how the heck do we do it, okay? So you may, if you've heard me speak, you've seen this this little visual also, the transformed health system. And what you'll notice about this is the treat circle is one part of the model. The clinical care is still a very important piece of this transformed system, but it is not the centerpiece any longer. And I think right now, if we were honest and we were drawing this diagram to say what's the current state, the clinical care treat piece would be most of the system. So in this vision, this concept of empowerment and equipping, well, again, how do we address empowering? This is exploring what matters most, the mission, and what we've learned through 8 years of trial and error and study is that that's actually really best done, not in the clinical visit and not by clinicians, surprise, surprise, but by peers who are trained to engage each other in that kind of a conversation. And that is amazingly powerful. And guess what? It's also more scalable, right? It doesn't have to be bottlenecked by clinicians. And as we said, it's not in and of itself not enough. So the equip piece of this model, this self-care emphasis, is where the focus is on skill building and support in combination with a clinical team that's aligned and trained in this way too. This slide just gives a little bit more details about each of what's in each of those buckets as we've evolved it. It's going to keep evolving and get better and better, I know. But the cool thing is this is not just a concept. This has been really well fleshed out, well developed, and well studied. And so we have, proof of concept upon which to build. So I just include a lot of these slides that I'm going to go into, I included for your reference, and I'll go pretty quickly through them. Not surprising, and also Wayne had a similar slide to this. The team is different. It's not just the current team, and I know I oversimplify the current team, but to say, the peers, in my opinion, these whole health partners are a game changer. And maybe those are community health workers who are trained in this approach. But the concept of peers from the community trained to do this part of the model is absolutely a game changer. And then a lot of the integrative health professions that we know, including coaches and nutrition and yoga and acupuncture, et cetera, now working in a system that's actually designed to allow them to do their thing, right? As opposed to trying to paste it on the outside of the current paradigm, which isn't designed to actually empower it. This is a very, very different model. So this is a drill down on each of these pieces. And again, I really wanted you to have this as a resource. So I will go pretty quickly through this because then I want to have a fair amount of time to talk about the Whole Health Institute. And lots of people have been asking me to say more about that. So if you think back to the visual that we used for the individual person, starting with their purpose, plus their self-care, plus their care team in the communities equals whole health, how does the system of delivery match up to that? Okay, so it's probably pretty obvious, right? My purpose is really in that is the empower piece, finding your purpose led by peers, as we said. The self-care is the equipping, new skill building and new support. How do you just learn new ways of eating or managing your stress or moving your body? How do you learn those skills to do it? And then how do you have the support? So these are actually well-being centers, right? This can happen in the community. This can happen in my mind. We have a vision where the future state is that the center of healthcare is not actually the clinic, but is actually well-being centers where you're exploring your purpose and having support and skill building to address your self-care. And then you go to the clinic when you need to. The care team, absolutely. To have this aligned and empowered by clinicians who are trained in this way, who do the clinical work in the context of whole health, is absolutely essential. And of course, communities is where we all live, right? So if we're addressing health and well-being only in the clinic or even in on the well-being center, and it's not pervasive in your community, it's not going to succeed. All right, so does it work? I think Wayne alluded to the fact that I might be referencing some of the outcomes with the VA because it's great data and you guys can use it. And I have the reference in here because it definitely makes the case of, is this a viable approach and does it have effectiveness? First, I wanted to start with individual voices. And these are 3 voices from 3 people on one visit that I made to one whole health group. And I wanted to say that because this isn't like cherry picked quotes from, you know, hundreds of people and we got picked the best. This was a group of about 12 folks who were in a whole health group led by peers. And, you know, I think I always think I'm not going to read these because you can read them, but I think it's important to have the voice of people in the room, the Zoom room. So I think, I think these quotes are actually really telling. So for example, the first one, right? Whole health began my journey to joy. So I love that, right? It wasn't about my hypertension. It was about my journey to joy. I am a changed person. This is a 52-year-old guy. I no longer need my cane. So guess what? There are real outcomes, right? The whole health group has become my family. It's about relationship, support. My neurologist said he doesn't need to see me anymore. So guess what? Reduction in costs and improvement in clinical outcomes. But hear the story, right? The next gentleman is a 71-year-old guy. I think he's so cool. I love this. Wait, you'll get to my favorite part in this quote. I have lost 33 pounds. I go to FIT class, which is a movement exercise class, a nutrition class, battlefield or auricular acupuncture, and regular acupuncture. Here's the line. My wife says I have a positive attitude now. I love that so much, right? Oh, and by the way, my diabetes is under control. My blood pressure is down. My lipids are good. I see my primary care doctor much less, right? So you hear it in their stories. It's about their life. And oh, by the way, their conditions are better too. And then a very poignant one, a 37-year-old woman. I used to drive over the Mississippi River Bridge to the Jefferson Barracks VA and think about jumping every time. The whole health system has helped me explore my purpose, find ways to use nutrition to reduce my pain, and use eye rest and Tai Chi to get moving again. Now I drive over that bridge and I think about tomorrow. I have hope. And I want to say that the theme that I have heard over and over and over again in conversations with people engaged in this whole health is hope. That's what I hear. They have hope again. And you know, when there's hope, needless to say, there's so much that's possible. So I promised to talk about the VA journey, and I put this timeline up just to give folks context for how this has come to be. And I won't go through every one of these bullets, but the essence of it is, you know, we, like the rest of the nation, had a vision for, yeah, we got to change this. This is doing more of the same is not success. So we all share a vision of, you know, greater health, well-being, integrative approaches, holistic philosophies. I mean, this wasn't new, but we didn't know how to create the system to deliver that. So the focus of the VA work was, well, what does it look like to create a system? And we started with broad think tank with national thought leaders. And then we created 8 centers of innovation. These were facilities who said, we don't know what we're doing, but we're going to sign up and try and dump in, and we're going to learn. We had over 200 grants of folks in the field who were doing aspects that looked really innovative. And we said, we don't know, maybe there's hope there. Maybe there's something there. We're going to fund that and we're going to learn from that. You know, from that, we went on to 25 sites. Once we started to get our hands around some of the core elements of this approach, 25 sites that were design sites, and they further evolved this approach. And then we aligned this with both opioid safety, suicide prevention, and employee health. So people started to understand, oh, this isn't like a program that sits over there. This is an approach that can impact all of these things, and most certainly including opioid safety, suicide, and employee health. And, you know, there's a big breakthrough in 2017 because we were actually successful in getting whole health and complementary integrative health services included in the medical benefits package for veterans. So that was, and we also realigned the reimbursement system so that the facilities would get reimbursed for that. So this is, of course, if we don't align the incentives behind this model, it doesn't matter how great the model is, transformation won't happen. So those were big turning points, I think, for the work. And then we launched 18 health systems that were fully funded, one in every network or VISN, if you're familiar with the VA world, that was called a flagship site. And those facilities were funded to launch all three pieces of the system: empower, equip, and treat. And they had support from the office for training and implementation. And we also had the opportunity to do real great research across those 18 facilities. In addition to that, there were over 140 facilities who were implementing aspects of whole health, but the 18 were funded and supported to do the whole enchilada of this now designed system to see, does it really work? I will just say that I'm going to give you some of the outcomes from those 18 in the first 2 years of the research. But I'm excited because the VA went on in 2020 to fund another 36 sites. So there's now 55 facilities funded and implementing the whole system. So it's a pretty grand experiment and pretty awesome. This is James Marzoff's data, who now works with us in the Whole Health Institute. And not to go into the details, but I wanted to show this particular slide because this is the alumni. This is the alumni. So what that means is a cohort of veterans who were no longer actively using whole health services. They had been, and then for 12 months they weren't. And what was really cool is that we saw costs decrease when people were active, but what's really exciting is to see the continued cost decrease, which we're presuming means that self-care that they were taught stuck, and they actually have changed how they're living their life. So to me, this is really exciting, a really exciting indicator. The next set of slides, which I will just hit the highlights on and then give you the rest, is the formal research evaluation across these 18 systems. And Ben Kligler, who I know you all know, who's now the head of the Office of Patient-Centered Care and Cultural Transformation for VA, is the lead on all of this and can certainly answer any questions. I did want to list out, when I said that we were successful in getting coverage, medical benefits coverage for whole health and complementary integrative health services, this list of services is what ended up included in the medical benefits package. So a big deal. And of course, it wasn't like, oh, if you want, get a massage and we'll cover it. It was clinically indicated, but these things are now mandated to be covered, which is a big deal. 31%, is it working? Okay, sorry. 31% of veterans with chronic pain across these 18 sites were opting to use whole health. And again, I'm going to hit the highlights of these. The impact was great. When you looked at whole health participants compared to non, 3-fold reduction in opioid use with patients with chronic pain. We also found, if you look at this bottom set of bullets, I love this. Perceptions of care were perceived as being more patient-centered. The veterans in whole health had increased engagement in their healthcare. They also had increased engagement in their self-care. And the one I like the most, because to me it indicates that we're getting somewhere with senses of meaning and purpose, they had increased engagement in their life. And again, if you agree with the paradigm that the purpose and the driver of healthcare becomes your life and your sense of meaning and purpose, that's really cool to see. That makes me really happy. This is just the graphic on the opioid utilization. And I think it is interesting to see that it does look like there's a dose response curve of some sort, right? That the more comprehensive, the intensive and comprehensive program was where we saw the greatest impact on opioid use. On the employee side, so this is a research team that was looking at the effect or impact on employees in the whole health system compared to employees in the usual VA system. And the bottom line is it had a great impact. And I won't read all the specifics, but the key things are lower voluntary turnover, so less resignations, less burnout, greater motivation in the people who were involved in whole health, the employees who were involved in whole health. The facilities overall also had higher ratings on overall hospital performance and higher ratings on patient-centered care. This is the graphic on the resignation rates. So you see it's across not only physicians and nurses, but all health service employees. So that's pretty exciting. If you look at costs, there was a significant decrease in costs for veterans with mental health conditions and also veterans with chronic conditions. And essentially, they still had an increase, a small increase in their pharmaceutical expenses, but look at it compared to the non-whole health group. So 3.5% increase compared to 12.5% in the non-whole health group, and 4.3 compared to 15.8. Again, please know you'll have these slides, and then this is the paper. This is the reference to the paper, so you can get all the details that you want. But I'm grateful to the VA and the amazing people there and the amazing veterans and the work that they have done to really flesh out this approach and get us real data in a system that is big enough for us to be able to do that. Okay, in the last little bit of time I had, people have asked a lot of questions to me about, all right, well, you left the VA. Why'd you leave the VA? And I'll tell you, I didn't want to leave the VA. I wasn't planning on leaving the VA because I love the VA and the work isn't quite done. But I had a great team there and they are carrying it on. And Ben's an amazing leader. But the real reason I left was because of this new opportunity. And that is the opportunity to create the Whole Health Institute. And as you heard in my intro, we are based in Bentonville, Arkansas. And the mission of the Institute, we already defined what whole health is: empowering and equipping people to take charge of their health, all aspects, to live a full and meaningful life. Well, the mission of the Institute is to make whole health available to all people in all communities. And I know that's like a very broad, amazingly big vision. And the reason that I think the time is right for that is not because of what we're going to do or what we can do, but because of what everybody else is doing. And what I mean by that, so many of us, like we were talking about in my intro, like for 20, 25 years, we've been on this journey and great work is happening. There has been great advances in the transformation of different aspects of healthcare, how we deliver healthcare, how we pay for it, how we educate, as a few examples. Lots of progress, but the big system, the big transformation hasn't happened yet. And why is that? In my opinion, it's largely because we haven't integrated across those silos. And I think prior to now, we probably weren't ready to integrate across those silos because the transformation work within those areas needed to be developed more. But I really believe that we are now at close to a tipping point. And if the Institute can help bridge these different systems that are trying to drive transformation and integrate and align them, now we have a chance to really flip it all. So that's the concept for the Institute. I use this kind of reflection of our outward work as well as our inward work. But if you look at kind of the outward work, because we don't need another institute to do what others are already doing beautifully and well. So, we're not recreating what you guys are already doing. But what I do think that the Institute can contribute that isn't currently present and available is to have this goal of transforming what I call a system of systems. So by bringing resources and efforts together across different transformational efforts, I think we can take this to another level. That means we're going to have unprecedented public-private partnerships and collaborations with people making progress. It's all about the collaborations. We can convene and catalyze thought leaders as another strategy and way to make this happen, while always paying attention to what I call living laboratories, just like we did in the VA. How does it actually work? What doesn't work? The answers are going to come from the grassroots strategies, and they will inform the rest of our work. So those things in terms of what makes us different in an outwardly facing way is how I think about it and how I conceive of it. So we thought about what are these systems? What are the systems that have to be transformed if this vision that we're all sharing is actually going to come to fruition? So this is our list of 13. I'm sure they're not complete. And if you guys, I would love to hear your thoughts about what's missing. There's lots of ways to dice it up, but the 13 that we list, I'm not going to read them. Not to say that the Whole Health Institute is going to drive change in all of those, but to say, you know what, all of these systems are players. And if, for example, we redefine how we deliver healthcare, but we don't redefine how we pay for it to align, it's going to fail, right? Or if we don't align how we educate people in the health system, it's going to fail. So I don't need to go through all that logic with you guys, but these are the 13 systems that we have identified. The ones that are highlighted are the ones that we are first focusing on. And I was hired about 1.5 years ago. So we have teams, small teams, mighty teams, and leadership in the areas of community whole health, health system delivery, medical schools and professional education, health sector finance and policy, and employers. And we're now adding food and nutrition this year. So those are the ones we've highlighted, primarily because we feel as though that's a place where we have some expertise and there's an opportunity to make a big impact pretty quickly. So that's kind of our logic there. I included this slide, and this is probably going to evolve over time, but as far as the Whole Health Institute is concerned, we do think there are efforts where we will hopefully help lead change because we have some expertise, it's important, and there's a great opportunity, and you can see those across the top. Then I think there are strategies or systems where we will help generate change, but not as much lead it as generate it, because there's a lot, for example, food and nutrition, tons of efforts going on about how do we improve food and nutrition and availability in agriculture. So we don't need to start that, but we do need to partner. And then big systems like big pharma and biotech and government, et cetera, where I think we are hoping to create change by catalyzing. So, and over time, these may change. We may take one out of one level and move it to a different one, but that's how we're conceiving of it at this point in time. I will say in the experience in education, you may have heard that we are starting a brand new whole health school of medicine and health sciences, which is a big undertaking in and of itself. That came about because the region here made a decision that they really needed a new school of medicine. And therefore, the Institute felt, well, if there's going to be a new school of medicine, let's not miss that opportunity to do it from the ground up in a radically different way. So that is what we're up to. The concept is not just a school of medicine, but the reason we say whole health school of medicine and health sciences is an opportunity to train the entire whole health team, like we've been talking about, together. A new definition of team-based learning, right? So stay tuned on that. We're hoping to matriculate our first class in 2024. So in closing, I wanted to just say, I always like to think about how we can fail. To me, it feels important for us to pay attention always to the likely places we can fail so that we're on alert. So I think we can certainly fail if we don't recognize this as multiple large system transformations. We can fail if we have only a focus from the top and we don't build it from the grassroots. We have to be informed continuously of how is it really in the communities, in the employers, workplace, et cetera. If we don't constantly expand and innovate our repertoire of approaches to well-being, we can fail if we don't align the resources and the measurements with desired outcomes. We've got to change that. If we continue to measure and value like fee-for-service kinds of things, episodic events, or transactions as if that's success, will fail. So if we don't use and value measures of lifelong health and well-being, we'll fail. So a lot of ways we can fail, but I think this is all on our radar screen. I bet none of these are surprising to any of us on this conference. So we need to just pay attention to it. So I asked myself, what would it be if I painted a picture of the future state? So this was what I came up with. So, imagine a day when the job of healthcare is to help people explore their sense of meaning and purpose and live their fullest life. If that really was the purpose of healthcare. Imagine a day when systems are reimbursed for improving well-being. When community whole health centers, where people have support and skill building, when that is the core of healthcare and the clinics and the hospitals are used as needed. When there are peer groups, whole health peer groups in every community and available to all people to just drop in. I think of it kind of like an AA thing, right? Like what if everywhere you go, there's going to be a whole health peer group and you can drop in anytime you want. When whole health is integrated across neighborhoods, across schools, and across workplaces. When this is Henri Roca's idea, when there is a designated whole health champion in every family. And then we get to the deeper stuff. When people's sense of meaning and purpose, connectivity, compassion, and collective humanity is profound. Imagine that this transformation in social consciousness results in a quantum leap in health and well-being. So that is my beautiful picture, my vision, shared by others I know. And I would like to, and if you guys have heard me talk, you've probably seen this 3-minute video because it's my favorite video in the world. I would encourage you, if you don't mind, to not say, oh, I've seen it and tune out. Every single time I've seen this video, and I see it all the time, I see something new. So what I'd like you to know about this before we try to run it, Jenny's in here to help me make sure it runs, is it's a true story. It happened to be, get the attention of a bank, and the bank wanted to share the story. So they made this video about it. So it's a true story. And the other thing you need to know is it's in subtitles. So you need to pay really close attention.
人为什么活着？
I think it's good.
为了思念，为了活下去，为了活更长，还是为了离开？ 去骑摩托车吧！5个台湾人，平均年龄81岁，1个重听，1个得了癌症。 3个有心脏病，每一个都有退化性关节炎。6个月的准备，环岛13天。 1139公里，从北到南，从黑夜到白天，只为了一个简单的理由。 人为什么要活着？
All right, did that work?
Yes, it was fantastic, even though I've seen it before.
I know, I've seen it so many times, you guys, and I just, I'm touched by it every time because it really, I'll pause that, I don't know. I think it just brings to life what we've been talking about, right? Like, yeah, you have cancer and heart disease and, you know, atherosclerosis, and are you going to sit around a table and wait to die? You know, are you going to actually think, what do you live for? So thank you so much for the opportunity to be a part of the conference. And I did take advantage of a little bit of that time Wayne gave me.
Well, thank you. I think we are still running a little bit ahead of schedule, which is fabulous. Great to have the extra time. Thank you so much, Tracy. That was really wonderful. I feel like I'm a little flustered after that video. Every time I see it, it gets me.
I know, me too. But that's good, right? Like let it touch our hearts and go, yeah, that's what it can look like. I love that. I love that.
Exactly. That's definitely what it's all about. So up next on our agenda, because I don't see we have any questions that are specific to Tracy. Let me check my question bank again real quick. But I think a lot of the questions are ones that are really everybody could address, and I want to make sure we're having a conversation about them. Yes, I'm going to say that they're all general discussion questions, which is fantastic. Thank you all for that. So we'll move on to our next agenda item, which is a break, actually. But we're going to do breaks a little bit differently than some people do breaks. And what we're going to have is a mindful move it session with one of our own, Yal Flesberg. And I'm making sure that Yal is here. Yes, she is. Excellent. Okay, so Yal, I'm going to give you a little introduction and then I will turn it over to you. Yal Flesberg is a Reiki master teacher, board certified polarity therapist, yoga therapist, leadership coach, organizational facilitator, and poet. At the GW Center for Integrative Medicine, she offers sessions in Reiki as well as yoga therapy. Her individual sessions help patients integrate physical, creative, and spiritual aspects into their own unique healing journeys. Thank you very much for joining us, Yal.
Thank you so much. All right, maybe we need a break from long introductions as well. So the first thing I'm going to do is, actually, I'm going to move back just a little bit. So Dr. Jonas talked about deep breathing, and so we can remain seated and just kind of do a little deep breath before we stand up and do a little bit more stretching. So I'll invite you to just take your hands right onto your belly. We'll breathe right down into the respiratory diaphragm. Take a big inhale through the nose, and then exhale, maybe this first couple of times through the mouth. Good. Inhaling. And exhaling. Good. So the next time you do this, as you inhale, notice that your belly just begins to move a little bit forward, but you can also feel it moving outward. And then on the exhale, just let everything relax. And if it's comfortable for you, you can always close your eyes here. Good. We're going to keep just breathing like that. We're just going to add a little bit of mindful movement into what we're doing. So as you're ready, you could just take your right ear over to your right shoulder. Hands can be on your lap or down by your chair, or you could take a hand just lightly on top of your head. Keep breathing all the way down. And maybe you'll even begin to feel a little bit of rootedness here. Good. Keep your head exactly where it is. Just reach that hand up and over. Come into a little bit more of a side bend. You could reach over just as much as feels good. The hand can also be on top of the head. Good. On your next inhale, come all the way up, and we'll just come to the other side, just really gently at first with the neck. Bringing your ear towards the shoulder, not really the shoulder, towards the ear. And just feeling that wave-like breath. And if you don't feel like doing the movement, don't worry, just do the breath. We can really learn a lot from just the breath moving within the body. You keep your head kind of heading towards this side. Maybe the hand goes down the chair. Opposite arm reaches up and over. Your hand can come to the back of the head if that feels good, just opening up space. What would it be like to slow everything down, even if it's just for a 5-minute break, a 10-minute break? Good. Come on up. And since we've all been on the screen watching, why don't we give our eyes a break? Rubbing your hands together pretty vigorously, creating a little bit of heat. And then you could just take those palms right over your eyes. Feel free to press a little bit. A little pressure is fine for the eyes. And then imagine that you're at the beach, looking over
Hello,
the horizon.
can you hear me?
Yes, we can hear you. Oh, I'm not sure if that was intentional.
Just keep going, Elle. You're doing great.
Okay. All right, and then we can release, shake out your hands. Okay, and let's just do a little massage for the head here. So your hands are sort of going like this. This is actually something that helps the brain wake up. We were just present at 2 amazing conversations. There was a lot in them. And the brain is working at double time. I'm noticing this because I'm just coming off of a concussion. So I've been doing a lot of these kinds of massages. Good. And then just like a rake, we're going to take our fingers right to the middle of a forehead and rake your skin out and just down towards the side. And I'm applying quite a bit of pressure here just to move some fluids around. Good for all of us who are getting a little older. And then you can sort of make a heart shape movement right on your face. Good. Good. And then we're going to do the same thing just underneath the head. So start by your ears. Again, 4 fingers. This is actually good for lymphatic drainage as well. And we're just going down from the ears towards the sides of the throat all the way down. You could go all the way down to the collarbones if that feels good to you. Just in a downward fashion. Some self-care that you could do. You could actually even do this during lectures. Shh. Good. And then we're just going to take fists right around the center of the chest, the thymus. And just take one hand out and you could just do a nice little pounding on the inside. Could come right through center to the other side. Good. And then let's again, you could do this in a comfortable seat or feel free to stand up if you're feeling like you'd like to do a stance. And so I'll show it standing up, but we'll just now take the arms all the way back behind you. If you'd like, lift up your gaze. And on an exhale, round the spine. So again, you could be doing this seated or standing. And then you could add the breath, inhaling as the arms go back, exhaling as they come forward. Good. Let's just do this one more time. Good. Take one hand in front of you, do the Fonzie thumbs up. And then we're gonna, with our eyes, gaze at your own thumbnail and just follow your gaze and your thumb just as far back as feels comfortable, and then come forward. So we could take a big inhale as we follow the gaze. Exhale, come forward. And again, remember, you could also be doing this seated. Inhale. And then exhale. Good. And we'll just switch it to the other side. Inhaling. And exhaling. Just adding in a little eye exercises here. Inhaling. And exhaling. Good. Last one. Inhale. You're going at your own speed, of course. And exhale. Good. And then let's just start shaking. So shaking out through those arms. Maybe allowing the shoulders to come up and down. It might be even more comfortable for you to shake one shoulder and then the other. Or you could just sort of shimmy going back and forth. Good. And then a few really big circles with the shoulders. Just going back. Could be a whole arm movement. And then we'll go forward. Good. And then let's take out just one last thing for the shoulders. We'll just take our arms into cactus arms or gold pose. Inhale here. And then on the exhale, bring the elbows towards one another. Just really nice and easy. Inhaling. Exhaling. Good. Inhale. And exhale. And if it feels good, we could sort of just add when you inhale, lift your chest, maybe your gaze. Exhale, bring the elbows together and look down. Inhaling. And exhaling. And just knowing when for your own body and mind it's time to expand and when you need a little rest. Just a few more times right here. Good. And then just let your arms just pause down by the sides of the body. And just take a rest. Just notice how you're feeling. Good. Finally, let's just come into a little chi shower. So we'll inhale the arms all the way up. Exhale, palms come down, and we're just drawing energy all the way down. Do this as muscularly as you like, or you could be really gentle here. You're just going with your own breath. Good. And on this last one, we'll just bring in all the good energy that we've cultivated. We'll just take one hand over the other hand on our belly, seated or standing. And just come back to that rhythmic, smooth breath. One last time, let's rub our hands together vigorously, giving our eyes a break. maybe this time imagine yourself on a high point. It could be in a penthouse apartment or on top of a mountain. Let your eyes see far.
Can you see me now? Hello. I haven't finished my makeup. Can you see me? Can you hear me?
Yes, I can, but Dr. Bayoumi, we were in the middle of a mind-body exercise.
I'm so sorry.
No problem. If you could just mute.
I'm so sorry.
Actually, I was just about to end. So that was wonderful because it made me smile so much, and I just wanted to hug you.
Little comedic relief.
Laughter is wonderful. Thank you.
Just dropped my glasses there. Thank you very much, y'all. That was really wonderful. I feel refreshed, like I can get back to typing more, which is what I'm going to have to be doing. So thank you for that.
Can I ask a question? Did I completely wreck everything for you? I'm so sorry with my
No.
No, we were just finishing up.
Good. All right.
And actually, Misha, we will be turning it over to you to do the introduction whenever you are ready, because now we are back on schedule.
Yeah, I actually think it was very, very telling how we moved very quickly from one point to the next. So Gigi already started her own introduction. So I'm Misha Kogan. I'm also one of the faculty here at GW. Before I introduce Dr. El-Bayoumi, I just want to mention something. So one of our updates is that's related to what Tracy and Wayne was talking about is, so we're quite in the middle of the COVID and now post-COVID. And I think we're attempting to figure out how we're going to bring some of the whole health and integrative modality to our post-COVID patients. So stay tuned. We're trying to get some grants, and I started seeing patients with post-COVID clinic. So it's going to be a kind of a new direction. I think we're going to see a lot of really long-term significant complications and be all dealing with this. But anyway, well, it's a tremendous pleasure for me to introduce our next speaker. I can definitely say that Gigi has not only been a flagship of kind of a heart of medicine at GW, but also my own personal mentor and later colleague. And I also just realized, noticed that 3 faculty on this symposium, Dr. Penn, Dean Bass, and Dr. El-Bayoumi, have all been trained here. In case of John and Gigi, their entire career has been on, and now Dean Bass has come back. So I think it's telling, and I'm quite honored that I'm around here too. So with this, so Dr. Jehan El-Bayoumi, she goes as Gigi, is the founding director of the Rodham Institute at the GW School of Medicine and Health Sciences. She's a full professor of medicine and a board certified internist. She has very busy clinical practice. I know that for sure, because I do see some of the patients that she refers to me. In 2013, in the honor of the late Miss Dorothy Rodham, Dr. El-Bayoumi established Rodham Institute that has since been applying a transformative power of education to achieve health equity in greater DC area. Rodham Institute strives to increase the number of underrepresented minorities and healthcare professionals, to partner with and support initiatives, programs, and objectives of community-based organizations that will improve health outcome for underserved population and educate current and future healthcare professionals in applied health equity with a focus of social determinants of health. Gigi received her undergraduate degree from Ann Arbor, and then she moved to DC, and she completed her internship residency, and then she served as a chief resident here at GW and stayed on faculty after. She was clerkship director for a number of years, and then for 15 years, she was the director of the internal medicine residency. So she trained numerous residents. Her clinical interests are women's health, minority health, and smoking cessation. In 2014, she received a certificate of appreciation from the White House for providing expert care to members of the White House staff. She sees a variety of different, not just the White House member, but all kinds of VIPs. She is very active in School of, in Milken Institute for Public Health. She's teaching on a variety of topics. And in 2020, just recently, she has received one of the most distinguished service awards from our own university as a SM, School of Medicine and Health Sciences Distinguished Service Award, which is given to faculty who has demonstrated exceptional service and citizenship to the GW School of Medicine. And especially, I just want to highlight that every time a patient gets referred to me from Gigi, they say that they feel like royalty in her presence, no matter whether they have, you know, a Medicaid or any other insurance. And I think this really tells who Gigi is, how big her heart is. And I think I'm proud of calling her my role model and my mentor. And I'm sure a lot of physicians at GW, as well as trainees, can do the same. And it's a tremendous pleasure to have Gigi start her talk, which is called Future of Medicine for All, which I think is perfect fit for this year's Song Symposium, because of course, the whole health has to be delivered to everybody, not just to those who can afford cash prices of it. Welcome, Gigi.
Well, thank you so much for that warm introduction. I really appreciate it. And, you know, while we were planning this, I said, you know, please don't do a long introduction. And then, of course, patients started to call and everything. I'm so glad that you did a long introduction, because that gave me time to put up my PowerPoint. So thank you for that. And thank you, Misha, for your leadership and your work, because, you know, I hope that everybody knows that Misha actually published the first book on integrative medicine in the geriatric population. He brought together his geriatric training with his love and interest and dedication for alternative and integrative medicine. So that is a Bible that I use, and certainly I've learned a lot from him. So what I'm going to do is I'm going to try to do this. I'm going to share my screen to allow, you know what I'm going to do? I'm going to do this. I'm going to cheat a little bit. I'm going to send this to you, Ms. Rodriguez, and I'm sure that you're listening, because I don't know how to do this so well. I'm just going to forward it to you. But while I'm forwarding it to you, let me tell you, we have been very busy at the Rodham Institute. But before I go into the Rodham Institute and the work and health equity for all, I just want to sort of share my personal story for you so that you can understand sort of the context that I'm coming from. So I was born in the United States in Florida, grew up in Michigan, and the daughter of two professors who are also activists. And I'm of Egyptian heritage. So in the summertime, we would go to Egypt, spend some time there, probably about every other summer. And so I feel very lucky that I had the exposure of both sort of Western culture, but also Egyptian, very, very old culture. My grandmother, who is my father's mother, was sort of one of the brightest people that I ever met. She was not, you know, formally educated beyond, you know, sort of the usual school. She didn't go to college, but she was a healer. And what was great about her as a healer is that she knew when to kind of use sort of the traditional treatments versus, you know, sending somebody to the hospital. And so I'm going to share a story with you that really made an impact on me. I think I was about 14 years old. So my sister and I went, just the two of us, to spend time with my grandmother. My sister was 11, I was 14, and my sister got sick with hepatitis A. And, you know, she was also very homesick for my parents. You know, my parents stayed in Michigan. It was just the two of us. We were there for about a month. And so as any child, you know, you kind of want the comfort of your own parents, especially your mother. So my grandmother said, I know what I'm going to do. I'm going to do a special treatment for you, she said. She came back with a newspaper and she cut out a paper doll. And that paper doll, she put like kind of a wire at the top. And she started to ask my sister, you know, who are all the people that you have seen today since you've gotten sick? So my sister mentioned all the names, and with each name, my grandmother would puncture a hole in the paper doll. And she said, are you sure you don't have any other names to add? I said, no, I don't have any other names to add. She goes, oh, wait a second. What about the cats? Yes, add the cats. And then what my grandmother did is that she burned this paper doll and she walked around my sister's bed 7 times, and my sister fell asleep. And we left the room and I said, you know, Gedito, do you believe in that stuff? And she said, it doesn't matter what I believe. It's what she believes. She's sleeping, isn't she? And so she had that sort of that healer's touch. But at the same time, when my first cousin, who was, I think, a year old, developed sudden abdominal pain, and my aunt wanted to take him to the hospital and her husband wanted to go to a wedding, she said that he said, no, we have to go to the wedding. My grandmother said, take him immediately to the hospital. And sure enough, he had volvulus and needed immediate surgery. So I feel lucky that I have sort of those traditions and can borrow sort of from both and understand both the benefits, but also the limitations of each system. So that's a bit about my background. And as Misha sort of mentioned, I am a general internist. I take care of a lot of patients, mostly outpatient, but sometimes in the inpatient setting, less so now. Although I was working in May for a week taking care of COVID patients in the hospital, and also a medical educator. And I want to tell you that we have problems in our healthcare system. And I think that COVID has helped to expose these problems for just ordinary people, ordinary Americans that may not have been aware until COVID happened. But I think that these problems have really existed for a very long time. So first slide is, what does health equity look like for all Americans? Next slide, please. Thank you. Disclosures, none. I'm an academic general internist. And as Misha mentioned at the top, I established this institute 8 years ago now in memory of Mrs. Dorothy Rodham. For those of you that don't know Mrs. Rodham, other than she's the late mother of Secretary Hillary Clinton, she was a remarkable woman. And I would really tell you and suggest rather to read a little bit about her. And everything I'm going to tell you is a matter of public record. I'm not saying anything private. She actually came from a very, very modest means, very modest means. She was actually deserted by her parents, and they shipped her off on a train when she was 7 and her sister was 5 from Chicago to San Diego by themselves. Imagine that. To her grandparents, who were really horribly abusive of her. And she became, quote, emancipated at the age of 14. And really it was because of the kindness of strangers. And they took her in and said, look, if you clean the house and basically get our kids ready for school and help them with their homework, we'll let you finish high school. And she did. She was also one of the smartest women that I ever met, but did not have the chance to get a formal education, unfortunately. But she poured all of her love and her intellectual curiosity and her love of reading into her daughter and to her granddaughter. And so I thought, what better person to choose to honor them through the Rodham Institute. Her love of education was very important. And she as a person was very modest and very down to earth. She was my patient. She would come, she would sit in the waiting area. Nobody would know who she was. She would wait her turn, just a, Midwesterner, right? And I think we also clicked on that level. Next slide, please. I want to just share with you a picture of Washington, D.C. Washington, D.C. is like a diamond, I like to say. And you can see that it's got two rivers, one that is on the northwest side, which is the Potomac, and then a sort of a natural other river, which is the Anacostia River. It's a little bit obscured by the lines there as a natural division point between Southeast and the rest of DC. You see where GW is at, and I'll talk about Berry Farm in a minute. Next slide, please. This is really something that if you have not seen this, I would recommend, and I'm going to give you the reference in just a second. This is from Uneven Opportunities. This is now about 2.5 years old. Virginia Commonwealth University, funded by Kaiser Family Foundation, put this 76-page document, which you can access for free online. And what is dramatic is that if, now remember, Washington, D.C. has a 10-mile span. And if you live in Trinidad, which is one of the sections of D.C., you can live, on average, your life expectancy is 67 years. But if you live in Georgetown, your life expectancy is on average 94 years. I mean, that's 26 years across the city, across the capital of arguably the richest country in the world. And remember, averages don't tell the whole story. Next paragraph. Next slide, sorry. This is, I just wanted you to see, it's Uneven Opportunities, and it's an online study of DC, Maryland, and Virginia. Next slide, please. So when you're looking at averages, it doesn't really tell the truth, the whole truth. And sadly, DC leads the country. We're #1, not in a good way, per capita of cancer mortality, HIV, and end-stage kidney disease. And if you kind of look further, we've got 8 wards. Ward 8 has the same HIV rates as Namibia and the same rates of infant mortality as El Salvador and Cambodia. 84% of the COVID deaths in DC were among the African-American community. That puts us at #7 per capita in African-American deaths in the United States. Next paragraph, please. Next, you can tell I dictate a lot, right? Ward 7 is also not a very rich ward, but it is a little bit more heterogeneous than Ward 8. Ward 8 is sort of uniformly poor. Ward 7 is a mix because a lot of retired government workers live there. There is more sort of, some of them own their homes. But for Ward 8 in particular, I would say you've got so many challenges. The healthy food options, there's actually only one full service giant that serves 79,000 people. Returning citizens, pharmacies that are not always open on the weekends or after hours, healthcare access, we'll come back to that. And then the emerging really structural and social determinant of health, which is gentrification. And I write Ward 9 up there, not because we have a Ward 9, we don't, but some people refer to Prince George's County, which is in Maryland, as Ward 9 because people are being displaced there from Ward 7 and 8. Next slide, please. So, we talk about the social determinants of health. I would add the word structural. That's actually from Dr. Arnaud, who is the head of health equity in the Department of Health. And really, if we think about the structural and social determinants of health, it's about the things that we cannot control. In the United States, the family that you're born into is the family that determines your health and life expectancy, which is very different than in other countries, especially in the industrialized world. For example, if you live and are born to a physician in Norway, that the possibility or probability that you're going to be a physician is not necessarily, doesn't necessarily correlate. Whereas here, that tightly correlates, and you're almost born into a caste system and you stay within that system. Although we love what we do as physicians and as clinicians and work in the healthcare system, really only about 20% of life expectancy is related to the healthcare system. Only 20%. Next slide, please. The other things include the water you drink, your educational level, the air that you breathe, the food that you eat. And I will tell you this. I told you that there's a 26-year span between the very richest and the poorest in DC. Education is one of the strongest social determinants of health and correlates with life expectancy. Right now in Ward 8, 42% of kids graduate from high school. Imagine if all we did as healers, as doctors, as clinicians, as nurses, was to get kids to graduate from high school. We would add 10 years to their life expectancy, just to give you some idea. The thing about Washington, D.C. that's so interesting, and this is a little bit different than other urban areas where there was redlining, where there were, very clear divisions, such as in Chicago, which there's Division Street, between white and Black communities. Anacostia, which is within Washington, D.C., is a little bit different. It was initially going to be a port for a federal city. And of course, there was opposition from Alexandria and Potomac. And Berry Farm was in Anacostia. Now, people tend to think of Berry as meaning or referring to the late sort of mayor for life, Marion Berry, but it's not. Berry Farm used to be the Berry Farm tobacco plantation. Next slide, please. And the freedmen were given, this is after the Emancipation Proclamation, they were given 400 acres that they transformed into a thriving farming community. After they would till the fields, they actually walked, which is a long walk, at least 6 miles, to build Howard University. They built it. And at its heyday, 1 in 4 adults attended Howard University, whereas now 1 in 4 are in the prison system. So when people talk about, Black folks don't eat fruits and vegetables and don't know how to eat and they need to be educated, well, actually, that's not true. If you talk to older people from Berry Farm, they will tell you, they remember when they would just pick an apple from the tree. I mean, it's a farming community. So things have been transformed. And I like to refer to Washington, D.C. as a city with musical chairs. And every time a chair is taken away, the people who are always left out are Black people. Because actually Georgetown has the oldest African-American church in the city. So people keep getting moved around. So Georgetown was an African-American community at one point. So was Capitol Hill. So is now Ward 8, but that's changing. And every time people get displaced. So I want to tell you about the Rodham Institute to give you some context, because it's not enough to talk about problems. I think it's just as important to talk about solutions. And I'd like to have some time to discuss these solutions with you. So the first thing that we decided is that we want the Rodham Institute to really be an action-oriented institute. Because if you think about health disparities, you can sum them up in one sentence. If you're poor, if you're Black, brown, or of color, if you're have mental health issues, if you're disabled, if you are a returning citizen, if you're undocumented, if you're homeless, if you're a senior, if you're LGBTQ, if you're deaf, if you're blind, your outcomes are worse. And also women, depending on what background. And if you think about it, all of us are eventually going to be in one of those groups, right? All of us. And so we wanted to really see what we can do and where we can really have the biggest impact. So we brought together 100 people from all over the city, from academics, interprofessional, and we asked the question, what should we focus on? And after 3 hours, we were told that education and food were 2 things that we needed to focus on. The education I understood, the food I had to come to understand, food is actually the number one social determinant of mental health. And this work comes from Dr. Michael Compton, who used to actually be in our psychiatry department, now is in the Department of Health in New York City. And he wrote an excellent book called The Social Determinants of Mental Health. It's an edited book, which I would recommend that you check out. And then Secretary Clinton gave us a charge and said, you know, it would be great if you could develop a model where you don't reproduce the wheel, where you share resources, which is sustainable and really can be upscaled. Next slide, please. So our guiding principles are these, and I think that this is so important for any work that's being done about health equity, and really should be the guiding principles of our healthcare system in general, right? The communities in the driver's seat. It should be inclusive, it should be consistent and respectful for people's dignity and their autonomy. We should build a bi-directional bridge, and that the gestures reflect the principles, and that we're transparent, and that there is reciprocity. So in other words, next slide, please, that we're not just there, you know, to pilot in, do a study, and then pilot out. No, we are clasping hands with the community to have them go from interdependent to independent, to be have self-determination. So what I call the Rodham Institute is, I call us glue. We convene, we connect, and we catalyze. One thing about DC, academic medicine in general, and other sort of microcosms that we live and work in, we're really quite siloed. And maybe that's one of the silver linings that the pandemic has shown us, is that we can no longer afford to be siloed. And we've been playing a role of glue for many years now. Fortunately, glue doesn't get a lot of funding, but we'll talk about that another time. Next slide, please. So here were some of the participating organizations. You can tell I had less gray hair there. Next slide, please. And so really our vision is to produce a cadre of healthcare professionals to really help to advance health equity, and is to partner, our mission is to partner with local DC community to achieve health equity. Next slide, please. Is that me or you? Oh, that's you. Okay. Next slide, please. So these are sort of the three areas, and then I promise to stop the formal, slide part. We do community collaborations, workforce development, and educating people who are currently working in the healthcare system about applied health equity and the structural and social determinants of health. Next slide, please. We started our work by actually commissioning a community health worker to do an environmental scan, because we wanted to know what the health priorities are of residents of Ward 7 and 8. And actually, to my surprise, although now I understand why, mental health, not HIV, not cancer, not obesity, was their number one health priority, which has really informed our work. Next slide, please. So I want to stop here and talk a bit about our work during the time of COVID, because I believe that this will serve as a model. And maybe we can stop the slides now, and we can just talk and have a discussion. So COVID, I always say, is the latest example of the health disparities in our city and our society. I would argue that COVID really, and how it was handled, really sent a very sad message to members of under-resourced, underrepresented, or minoritized communities, and that is, you don't matter. So if you remember the past administration, when COVID deaths were happening, they said, well, if you're 70, you've had a good life. So basically, forget seniors. If you have, underlying conditions, well, you didn't really die of COVID. You died of diabetes, which makes about as much sense as somebody going in an airplane and the plane crashes and they say, no, they died of diabetes and not the plane crash. And then finally, certainly if you're Black and brown, since a third of deaths were happening, then you didn't matter. So really, if we think about our medical system, it is a system, especially now with COVID, that you need. It's not only about being educated, it's also about having the wherewithal and sometimes the resources to navigate the system. So I'll give you an example. One of my patients is a billionaireess. So when the vaccine came out, she actually chartered a plane down to Florida, got her vaccine, came back, and 3 weeks later, chartered a plane back down to get her vaccine. So yeah, some people have access and others do not. But I think what happened with COVID is then you began to see how all of these other social and structural determinants of health really began to impact health, right? Poverty and education and all that. But not just that COVID actually increased the divisions. So let's take an example, the digital health divide. Well, so when we were adapting to COVID in the healthcare system, we said telehealth. It's like, okay, great, people can have access. And, it was more convenient for some people, got rid of some of the transportation barriers. And patients love it. Clinicians, I'm not sure yet, because there are certain challenges there. But, okay, that was a great, we adapted. Except for the people that don't have internet, that don't have computers, and even if they do, don't have computer literacy, right? And remember, 1 in 3 Washingtonians are functionally illiterate. That's just regular reading and writing. We're not even talking about computer literacy, right? Which we know is a whole other thing. And I can tell you, I can attest that at the beginning of the Zoom calls, I would see the top of somebody's head or maybe, the ceiling someplace. So that's for people who have the technology. So actually this divide is increasing. In education, which I just said was a key social determinant of health, the divide is increasing among Black and brown kids. And then you layer on top of that, Black and brown kids who are disabled, they're actually losing not 1 grade, but 2 grades. And that's another point I'd like to make. And that is we tend to, and I'm doing it to a large extent right now, kind of paint a minority or a group with one brush. And it's much more complex than that. I think we tend to forget about minorities within minorities. For example, disabled children in Ward 8 have triple and quadruple the challenges that disabled children who live where I live in Ward 3. Or undocumented folks who are disabled or who have mental health issues or are homebound, or I think you get the idea, is that we have to be careful when we're looking at these issues to try to get some really granular information, because that's going to be more meaningful as we think about the ways that we're going to have a solution. That's going to be really important. So I know I have a few more minutes left, and I'm just going to present to you what I believe is the way that we can solve some of these problems. My father, who's a retired physical chemistry professor, says, when you're dealing with a complicated problem, it's kind of like eating a hamburger sandwich or a vegan hamburger sandwich, plant-based. And that is, you don't eat the bread and then the tomato and then the lettuce. Somebody's unmuted. Maybe you can mute. I think that's, yeah, somebody's unmuted. I can't tell who. There we go. You don't eat the bread and then the lettuce and tomato and then squirt the ketchup and mustard in your mouth. No, you have to eat everything at the same time. And so it is with health equity, because it is about economic development. It is about education. It is about housing. It is about mental health. It is about the healthcare system as well, certainly. It is about food. It is about environmental issues. It is about social justice and justice in the courtrooms. It is all of these things, right? I think that health is sort of the canary in the cage. If you look at our numbers in the United States of America, we're not number one, we're number 40 in terms of health outcomes in the world. That's pretty bad. And so it was predictable on some level that when a pandemic hit, that we would have an uncovering of all of these issues. But I believe that we have an opportunity to holistically, and by the way, economically, even though there's some initial investments of monies that have to be done in terms of infrastructure and a lot of these other things that we're seeing this administration put into, it's actually going to save money at the end. Because for being number 40 in health outcomes, we're number 1 in terms of expenditures. So I'm going to close by sharing our recent mass vaccination campaign where we got 886 people vaccinated on one day in Ward 8. First of all, we were invited by the former mayor, or the late mayor, Marion Barry's widow, to come and do this vaccination event at the Southeast Tennyson Learning Center. Then what we said is, sure, we'd be happy to, but you know what? I had noticed a lot of mental health issues and food issues among my patients. Wouldn't it be great if we brought in those people from Food and Friends, Capital Area Food Bank, to be there? We also brought Whitman Walker, who did education about PrEP and PEP. We brought health literacy. But the thing that I'm most proud of is that we brought every single academic institution. We brought Children's and GW and Howard and Georgetown. We brought the community-based organizations were actually the ones that were leading the charge. They were the ones that were registering patients. They were the ones that had the 3 touch points with patients before, or residents, I should say, before they came for the vaccine. I'll be happy to talk a little bit more and give you a little bit more in the way of details, but this model is not a one and done. It is just the beginning of what we hope to continue. And it's not unique, but I just wanted to share that with you, because if we're going to be effective, we have to let the community-based organizations be the leaders. We did train the trainers so that they would know what information, we answered their questions about the vaccine, but that also helps increase the social capital of the community itself, right? And they became ambassadors for the vaccine. So I'm going to stop there. I can obviously talk for a very long time. I want to just thank you for the opportunity to speak, and I hope we have some time at the end for some discussions. Thank you.
Thank you so much, Gigi. That was so necessary to have in this conversation. And you did a really great job of highlighting all the components, the moving parts. This is not an easy problem to solve, but that doesn't mean we can't solve it. And I think we have the right people in the room today to possibly solve this. So I'm going to go ahead and move on to the next speaker. I also did realize I didn't actually introduce myself, and some of you do not know me. So I will introduce myself quickly. My name is Lee Frame. I am the Executive Director of the Office of Integrative Medicine and Health. So that's what you need to know about me. I'm also a researcher by training, and I love talking about all things integrative medicine. So I'm excited to be here. And I'm really excited to talk about our next speaker. Let me pull up her bio. Sorry, my computer decided it didn't want Microsoft Word to be running anymore. Okay, here we go. We are really honored to have Dr. Elaine Langevin with us today. She was sworn in as the director of the National Center for Complementary and Integrative Health, or NCCIH for short, on November 26, 2018. Previously, she served as director of the Osher Center for Integrative Medicine, which is jointly based at Brigham and Women's Hospital and Harvard Medical School, as well as professor in residence of medicine at Harvard Medical School. Dr. Langevin's research interests have centered around the role of connective tissue in chronic musculoskeletal pain and the mechanisms of acupuncture, manual and movement-based therapies, including the effects of stretching on inflammation resolution within connective tissue, which I've seen her give a talk about, and it's really fantastic. So that's another thing you've got to find on the internet is her talk about that. She's authored more than 70 original scientific papers and is a fellow of the American College of Physicians. Dr. Langevin earned an MD at McGill University. She completed a postdoctoral research fellowship at the MRC Neurochemical Pharmacological Unit in Cambridge, England, as well as a residency in internal medicine and fellowship in endocrinology and metabolism at the Johns Hopkins Hospital. As NCCIH director, Dr. Langevin oversees the federal government's lead agency that funds and conducts research to help answer important scientific and public health questions about natural products, mind and body practices, and pain management. The center also coordinates and collaborates with other research institutes and federal programs on research into complementary and integrative health. Before I turn it over to Dr. Langevin, please keep the questions coming in the chat. Dr. Langevin will actually have some time to take NCCIH specific questions immediately after her talk, and then we'll do another mindful movement break and head into the panel session. So with that, I will welcome Dr. Langevin.
Thank you so much. It's such a pleasure to be here and to have the opportunity to talk about the new strategic priorities of NCCIH around the theme of whole person health. And we had the perfect introduction to this by Dr. El-Bayoumi's presentation that really illustrated how a holistic approach to health is so, so important. So I'm going to be sharing my screen. Can you see this?
Yes.
Okay, good. So the NCCIH is currently going through our strategic planning process for the next 5 years. And in the process of doing this, we have been sort of re-examining the meaning of the term complementary and integrative health. And I want to illustrate this for you. Going through the letters CIH one at a time. So the first is our middle C for complementary. And the term complementary evolved from the term alternative. 20 years ago, when NCCIH used to be NCAM, for National Center for Complementary and Alternative Medicine, the term alternative was sort of a term used to describe treatments or practices that may be used as an alternative to conventional medicine. And we've been sort of going away from that. We really feel that the important thing about complementary therapies is that they can be used together with, in an appropriate way with conventional care. And so gradually these complementary practices are being integrated into the mainstream of healthcare. And we've been illustrating this with this sort of diagram here that shows sort of these major categories of treatments and practices, being nutritional, psychological, and physical, and how these overlap with some of the more traditional categories like drugs, for example, devices or surgery. And importantly, these categories have also overlap with each other. For example, there's a considerable overlap between the psychological and the physical category. Psychological practices might include, for example, mindfulness-based stress reduction or other meditative practices. But there's also a fair amount of overlap between conventional, say, psychotherapy and cognitive behavior therapy that gradually is incorporating things like mindfulness and relaxation techniques. Also, overlap between the psychological and the physical categories in a sense that there's a lot of techniques, for example, yoga and Tai Chi, that have both a psychological and a physical component. Again, more physical, pure physical types of treatments, like manual therapies, for example. There's an overlap between that and conventional physical therapy, which is beginning to incorporate a lot of techniques derived from massage or spinal manipulation, for example, derived from osteopathic or chiropractic techniques. And then there's acupuncture, which, as you can see, sits kind of at an intersection between psychological, physical, and devices, because acupuncture needles are essentially little devices that can be connected to different types of stimulation, for example, electrical stimulation. So as you can see, and then if you look at the nutritional category, there's again an overlap between, for example, dietary supplements and drugs, because some supplements can be used as prescription, can be classified both as the same component. For example, niacin can be classified as a dietary supplement or a drug, depending on the dose used. So, and again, I want to point out an intersection between the nutritional and the psychological category in the form of mindful eating. So you can see that this is a complex map that is likely to evolve. But we like to think about it this way, as to show the sort of the distribution of these complementary therapies. The other important thing to note is that here, these types of therapies have been used, are listed sort of as in isolation, kind of one at a time. But in practice, very often they are combined. For example, traditional Chinese medicine, for example, used a combination of nutritional and also, for example, Tai Chi, which would be a psychological and physical, and acupuncture, as well as application of heat or cold. So you can see that what we call these multi-component therapies that can be joined together in what we call a multi-component therapeutic system that has its own sort of theory, and sometimes there's an underlying theory, and sometimes even diagnostic kind of framework that ties these techniques together. And we think that these are important to study, not only in isolation, but as a system. So the kind of description that we have arrived is, for the word complementary, is that these complementary therapies consist of practices and systems and therapies that use dietary, physical, and psychological approaches, and may have originated outside of conventional medicine, but are gradually being incorporated into mainstream healthcare. So let's move on to the next letter, which is the letter I for integrative. When we think about integration or integrative health or integrative medicine, we usually think about bringing conventional and complementary therapies together in an integrative way, and that's true. But at NCCIH, we also think that the word integrative goes further than that. And what do I mean by that? Well, whenever you have any kind of scientific discipline, even mathematics or philosophy, you always have these two sort of countercurrents of analysis and synthesis. Analysis is when you break things down into smaller and smaller components, and then synthesis is when you put them back together into the whole. Or another word for synthesis is integration, right? And in conventional medicine, we're really good at analysis. Starting with breaking down the system into the body, into various different physiological systems, and then into cells, and then into signaling pathways and molecules. And this has resulted in a very, very sort of biochemical approach to understanding the functioning of the human body. And it makes sense that the overwhelming approach that is derived from this is biochemical and is basically pharmacology. Because if we think about diseases, for example, in terms of sort of molecular pathways, the way to intervene and to manage these diseases is, again, through biochemistry. But it's also important to think about how and why this occurred, and why this reductionistic approach. It really started way back at the beginning at the end of the 19th century, when the various organs and systems of the body were beginning to be understood. And this has determined the structure of our medical specialties, and also medical academic departments, and even the NIH, organized along organs and systems and diseases. So I'm going to illustrate this with a case history. This is a history of a 50-year-old female with type 2 diabetes. She's overweight with a BMI of 30, and efforts to control her blood sugar with diet have been so far unsuccessful. Her doctor starts her on metformin and then glipizide, which has kept her hemoglobin A1C within the normal range for the past 2 years, although her BMI is now 32. She has a 10-year history of hypertension that was controlled with hydrochlorothiazide until 3 months ago when an ACE inhibitor was added. This was discontinued 2 months later due to a persistent dry cough, and a beta blocker was added to her regimen. Her blood pressure is still slightly elevated. The cough symptoms improved after discontinuing the ACE inhibitor, but have not completely subsided. She had osteoarthritis of the right knee, managed with Motrin and Tylenol for acute exacerbation. She has a long history of anxiety, difficulty sleeping, and intermittent epigastric pain attributed to gastroesophageal reflux. She's been prescribed Ambien to take as needed for sleep and Prilosec for her heartburn. She's concerned that her GI symptoms are due to one of her diabetes medications, but was strongly encouraged to stay on these since they are successfully controlling her blood sugar. She also has slight iron deficiency anemia, which is being worked up for a GI source. And she was told to discontinue the Motrin and take Tylenol instead. Now imagine the same patient 30 years later in a nursing home. Her diabetes and hypertension are still under reasonable control with a total of 4 medications, but her insomnia and chronic knee pain are increasingly problematic. She has not been able to sleep at all without medications for many years. She's had some cognitive decline, daytime somnolence, and worsening anxiety. In an attempt to wean her from benzodiazepines, she was started on trazodone with some benefit, but has recently developed worsening tachycardia, which is being evaluated. She had a GI bleed from erosive gastritis in her mid-60s and can no longer take NSAIDs. And she has needed stronger analgesics to control the knee pain with occasional opiates for acute exacerbations. What's wrong with this all too familiar picture? The patient is suffering from having been broken down into separate body parts. And each of her problems is being treated as a separate disease. And the resulting polydiagnosis and polypharmacy create an additional layer of iatrogenic drug-induced pathology. And failure to understand the importance of seeing this patient as a whole person has led to her being treated using a fragmented, disease-focused model that encourages a reliance on pharmacologically controlling separate diseases rather than restoring health. This is obviously a serious problem. Now, what is the solution? Well, clearly what we need to do is point the arrow back towards the whole patient. But that's not easy to do. Lately, we've seen a lot of efforts to talk about both personalized medicine, individualized treatments, and precision medicine. And we also talk about whole person health, but sometimes the words get confused. The word personalized, for example, gets used both in the context of a whole person approach to biopsychosocial approach to understanding the whole patient, but also the same word personalized gets used to describe precision medicine that is aimed at specific, for example, molecular targets based on genetic alleles, for example. So more and more, we're starting to understand that we need to integrate, and the fields of integrative physiology, systems biology, and genome-wide association studies are starting to move the needle back towards integration, back to understanding the systems that tie all of these phenomena together. But this is a long process. So at NCCIH, we feel that this is a very important part of what we need to do. We need to advance research, not only on the integration of a complementary and conventional care, but also we need to promote an integrative approach to physiology, understanding the normal functioning of the body, pathophysiology, and treatment. So let's now move to the letter H for health. When we think about health and we think about disease, they're not discontinuous states. There are gradations in between. And as somebody moves from a healthy state to a less healthy state, to finally to a frank disease, there is a point where some signs begin to appear of distress or of dysfunction. The patient may have a poor diet, for example, may have a sedentary lifestyle, not getting enough exercise, may be under psychological stress, perhaps they're having difficulty sleeping. And the important thing is that these common problems are really predisposing factors to a number of different diseases of separate organ systems. By the time that they are at the disease stage, that's the case of where we start thinking about them as separate problems. But if we look back to these predisposing factors, we see that the same psychological stress, poor diet, and sedentary lifestyle very much occur in the same people. The people who are very often under disadvantaged socioeconomic conditions, under the same people who suffer healthcare disparities, the same people who are disproportionately affected by coronavirus epidemic, and the same people who are also at increased risk for chronic pain, for opiate addiction, and for suicide. And so these are not disconnected problems. If we think about it this way, and we think that not only do all of these separate, what we call co-occurring or comorbid diseases have common predisposing factors, you can use the same argument to argue for a integrated approach to reversing some of these problems before, while they are still at a stage where they may still be reversible. And so an integrated approach including both self-care and multi-component interventions, including nutritional, psychological, physical interventions, such as the ones that I was showing earlier, this is how we think that we can intervene in what we call a multi-component approach or integrated approach to restore health. When we think about even preventive medicine, we are usually so much oriented towards disease that we think about it in terms of disease prevention, but we need to increasingly turn our focus towards health restoration. How do we assist and empower people to improve their health in multiple interconnected domains: biological, behavioral, social, and environmental? Now, how does this happen physiologically? If we think about pathogenesis, which is really, these are mechanisms of disease, right? And if you think about these two, I've represented here these networks. Imagine the blue network being a healthy network and the red network being less healthy. You can imagine that if somebody is moving into a less healthier state, that the red network would gradually get more and more distorted compared with the blue network. Now, what about when somebody goes back towards health? Does the same process occur in reverse? And this is where the word salutogenesis is very interesting here, because if we think about, is the reverse of pathogenesis when somebody goes back from a less healthy state to a healthier state, does that kind of just recapitulate the steps of pathogenesis or in reverse? Or do some specific healing pathways, for example, need to be activated in order for the person to become healthier? And these pathways could be, they could be biological, they could be psychological, they could be behavioral. We don't know because we haven't studied it this way. And at NCCIH, we're very interested in this process of understanding salutogenesis. And we are just recently, we have partnered with several other institutes at the NIH we've issued a notice of intent to publish a funding opportunity for studying salutogenesis as part of an artificial intelligence opportunity to get, for example, researchers with an interest in various aspects of health, and engineers and computer scientists who have an expertise in artificial intelligence, because we think that in order to understand how these complex networks change over time, either towards disease or back towards health, you really need those types of very sophisticated tools. So we're very excited that NCCIH will be part of this. So just to summarize, the health, how we think about health now is that at NCCIH, we want to address health promotion and restoration, as well as disease prevention and symptom management. Of course, managing symptoms is important throughout the health span, but we want to make sure that these symptoms don't get managed in an isolated way, that there's always an eye towards improving the health of the individual. And so we think that at certainly, this is the way that we have been describing this. At an individual level, you can think about the various biological, behavioral, social, and environmental domains of health on this kind of what we call the vertical axis. And then on the horizontal axis, we have what we call the bidirectional health disease continuum, where an individual throughout their life is really kind of moving back and forth between these two states. And this is not static. An individual may, for example, have an acute illness. And for example, coronavirus, COVID-19 is a perfect example of this, where the individual may not return to health fully right away. And there's a process that is necessary in order for the person to regain their health. We really need to understand how that happens and how sometimes people who have these kind of long-term sequelae of COVID-19, why is that? Why is it that some people don't go back fully to health for a while? The same thing with bacterial infections. In the old days, before antibiotics, if somebody had a bacterial infection, a lot of attention was paid to what they called the convalescent period. If you read, novels from the 18th or 19th century, that was a critical time if somebody was recovering from pneumonia or from some kind of another type of bacterial infection. And there was a lot of attention paid to gradual return to physical activity, to diet, and to make sure that the person didn't have a relapse. Now we have powerful antibiotics where we take a course of antibiotics and then we assume that the person is going to be back to health after this. But we know that that's not always the case. And we also know that, for example, the microbiome gets very much affected by antibiotics. And it takes a while for the microbiome to recover, after antibiotic treatment. Another example is a chronic remitting or relapsing condition like inflammatory bowel disease or rheumatoid arthritis. Patients will go through cycles of exacerbations and remissions. What can we do to assist patients when they are in a remission, to stay in remission and prevent them from having another flare? Recovery from an accident or an injury is similar. Once the bone has been healed back together, there's still a long period of time that needs to be, and where particular attention needs to be given to rehabilitation, restoration of movement, restoration of physical stamina. These are all part of what we call health restoration. So the other aspect of this is that clearly this is not simply at the individual level. The same principles can be applied to family, to community, and to whole populations. Right now, the population of the United States is in a very poor state of health. This is documented. The life expectancy in the United States has been declining now for several years in a row. This is a very alarming statistic. And we have all of these confluent crises, converging problems that are disproportionately affecting patients of minorities and people with healthcare disparities. That is very, very troubling. And in addition, what we think is contributing to this is the fact that we have a fragmented approach to health that really looks at problems in a disconnected way, in a non-integrated way. And so we think that integration is really very much part of the solution to this. So I have kind of described to you the three components of complementary and integrative health, describe the complementary therapies, practices, and systems that are gradually being incorporated and integrated, not just with conventional care, but also integrated at every level of understanding health, disease, and treatment, and understanding the bidirectional health continuum and the two components, the two important components of whole person health, the integration in this sort of the different domains of behavioral, psychological, social, and environmental, as well as the time domain that describes this bidirectional axis of health or disease through which we are traveling for our entire lives. So I encourage you to visit our website, nccih.nih.gov. We will be posting the final version of our strategic plan very soon. We really want to thank all of the people who have contributed to this strategic plan via comments on our request for information. And also check out there's a lot of very exciting funding opportunities that we post all the time, including the Bridge to AI artificial intelligence projects that I mentioned. And also please follow us on social media, Twitter, and we really look forward to hearing from you. Thank you.
Thank you. That was wonderful. And I think a really nice end to our day. You kind of wrapped everything into a nice little package with a bow. So if there are any questions directly related to Dr. Langevin presentation, related to NCCIH or some of the strategic initiatives, you can go ahead and put them in the chat now, as we have time to get questions directly with her. And if you're having trouble typing them in, you may be able to unmute yourself and ask. That may also work. Well, while we're waiting, I know one of the things that I've always wondered about with NCCIH is how can one organization do so many things? Right? You know, integrative health is so big, and I struggle with this at GW. It's so big, and there's so many things that need to be done, and you need to have mechanisms behind it. So we need to do basic research, but then we need to know how it works in humans. So we have to do clinical trials. And how can you manage all those different priorities and still be effective?
Yeah, that is such a good question. And we struggle with that at NCCIH because we are one of the smallest centers at NIH. And the way we do this is by partnering. So we are leveraging a lot of our efforts with other institutes and centers at NIH. And we partner with, for example, the HEAL Initiative. So the HEAL Initiative is a trans-NIH effort that is for addressing the opioid epidemic and for improving the management of pain and opioid use disorder. And NCCIH is very much involved in this, and we have received a lot of funding through that, through the HEAL Initiative for projects that are both that address what we call pragmatic and implementation trials. These are clinical trials that are in the healthcare setting, like in the real world as healthcare is actually occurring. And also what we call implementation is very important. If we have evidence that some therapies, for example, some non-pharmacological approaches for pain are effective, but they're still not being implemented. And we still know that still way too many physicians prescribe opiates for somebody who comes in with either acute or chronic back pain, for example, when it clearly the clinical guidelines say that you should not do that. Why is it that they're not referring to physical therapy or to acupuncture or to massage? Well, there are reasons for that. And that's what we want to study is why is this and really address it. And the other, so that's one piece. And then there's other, for example, the Healthcare Systems Research Collaboratory, which is another very trans-NIH initiative where we partner with a lot of institutes, National Institute on Aging, Child Health and Human Development, and nursing, for example. And so we really leverage our resources and we try to engage the other institutes so that they start addressing integration as part of their own research portfolios. So I think this is the way to do it. we can't do everything, obviously, at NCCIH, but we can inspire, I think, people to think in an integrative way.
Yeah, that's a really great point. Collaboration, it's always the answer. Speaking of collaboration, we have a question here about grants. So should a grant submitted for the June cycle highlight alignment with the soon to come strategic plan?
Sure. I mean, the strategic plan, we think, is going to be posted in May. If all goes well, we should have it out by our May council. And so it is perfectly appropriate to refer to the strategic plan in a June application. Yeah, absolutely.
Follow-up question, I'm thinking what they're asking is, what if they don't address the new strategic plan?
Well, the new strategic plan, we didn't throw out the old one, right? So, so the NCCIH is building upon our foundation of what we have done in the past. So in the past, there was a strong effort to understand, for example, and develop, understand mechanisms of, say, pain, for example. We had a strong interest in pain, which we continue to have mechanisms, pain mechanisms, treatments, as I said, effectiveness, implementation. Natural products is another area of, and then that's being wrapped into this nutritional category. But if you look at it, the natural products are still in there. The mind and body therapies that we used to call, where, yoga, meditation, mindfulness, that's still in there. So the old strategic plan is there. All the content is there. It's just that we've rethought how we've organized it. So, and we've put more of an emphasis on the whole person health kind of framework. But there's really, we didn't throw out the content of the old plan. So you're fine.
Perfect. That's good to know. I'm sure they'll feel at ease now with their grant.
Oh, yeah.
Grants are easy. Next question. What do you see as the biggest obstacle for complementary and integrative health now? It's a big question.
Money. I mean, really, a lot of these therapies are still not reimbursed. And this is the problem. I mean, a lot of patients cannot afford them. So what do we need to do? We need to work really hard on developing not only the evidence base, but also work with for example, our partner sister organizations. We're currently, one of the grants that was funded through the HEAL initiative was in partnership with the Center for Medicare Services for coverage of acupuncture for low back pain in older adults. Now, this, importantly, this project is going to be used for evidence-based coverage determination. And so once Blue Cross and Blue Shield hopefully will start to cover acupuncture, then, once Medicare starts to cover acupuncture, other insurance companies like Blue Cross, for example, may follow. So I think this is very important, that insurance companies need data. They need information in order to justify the reimbursement of these services. And that's what we need to provide. And we need to provide not only do the research, but disseminate it, make sure that people know about it. So that's really important.
I very much agree with that. We have a question here from Dr. Jonas. Will you be looking at the use of AI for salutogenesis in cancer? Seems like that might be low-hanging fruit.
Well, this is up to the investigators who want to. The AI opportunity, if you look on the website, is really about developing the databases and the structure, the infrastructure to actually do the artificial intelligence analysis. Whatever projects people want to propose to generate the kind of data that they want to generate, that's totally up to the investigators. The salutogenesis is one of the ideas, examples of the type of project it could be that's of particular interest to us at NCCIH. But there's many others questions that, of course, an approach like this could be used for. So it's a very exciting opportunity to really start answering, developing platforms to then be able to test hypotheses. But with artificial intelligence, the important thing is the data comes first. The hypothesis doesn't come first. It's kind of flipping things around. Usually when we do regular research, we start with a hypothesis and then we collect the data. With artificial intelligence, you start with the data, which is really interesting. And you have to collect the data in such a way that it can be used for artificial intelligence. The data has to be annotated properly. It has to be all organized in a very specific way. Then you mine the data, and then you can then use this to develop models to test hypotheses. So it's a very, very interesting approach that has a lot of potential for examining complex systems. And the complexity of health is, there's probably not too many things that are more complex than that. So it's really made for this. It's a very important, kind of opportunity to put the right tool to the right problem.
It is an exciting tool, and I know that's an NIH-wide priority, so hopefully that will be helpful as well. Another question about what the top priority for NCCIH is in terms of children's health.
Oh, well, we're very interested in, for example, emotional well-being in children, in schools, and well, across the lifespan. I mean, it's not, we don't have specific projects for children, but we're interested in the lifespan, the whole development of the lifespan, from childhood to young adulthood to older adults. And so, but especially for things like, for example, emotional and physical well-being. This is very, very important in making sure that children have a good start in life, and that areas that are creating stress in children, that we have ways to mitigate that. And because we know that, that this can have an impact for the rest of their lives, in terms of creating what we call allostatic load. When children are exposed to a lot of trauma, a lot of stress early on, you can kind of develop sort of chronic stress responses that can linger on even after the stress is been removed. So it's very important to look at early life. So yes, we're very interested in this for sure.
A related question is, will you be looking at the youth and education for body literacy, health through whole health ed, and the youth participatory action research to see if we educate them about their bodies in a meaningful way early? Would something like structural equation modeling help us learn about the complexity? And that question is from Diane, who may need to provide more information.
Yeah, I don't know these particular modalities, but a lot of what it sounds like, it looks like it fits very well within the framework that I described. So importantly, I have to say, our strategic plan it's not going to say we're going to fund this and this and this and that. It provides a framework, and a lot of individual approaches, therapies, problems, hypotheses, they can, if they fit within the framework, then it's within our areas of interest. I mean, so the idea to read a strategic plan is not to go and look for one particular word or, oh, it's not in there, so they're not interested. No, it's really meant to kind of be a whole. So that's the right way to think about it.
So now a question about energy therapies, such as Reiki. Where do you put that in holistic therapies?
Now that's an interesting one. So, one of the areas that has been really, a little controversial in complementary and integrative health has been the areas of what we call energy medicine. And the research on this, I think, has been really lacking. I think that I would approach this from the point of view of methodology, the same way that we would recommend if somebody, for example, wants to do research on like an area that's still under development, like we haven't had a whole lot. I mentioned something like, for example, Ayurveda or traditional Chinese medicine. Well, I think energy medicine falls into that sort of category where we really need to understand, how do you study this? What is the right approach to understand kind of the right questions to ask? I would say for energy medicine, a specific important aspect is to say, what is the right question here? Is the right question, for example, to try to say, is there any, for example, evidence that if somebody does an experiment in a system of, for example, a plant or with cells in a culture dish, and you can determine that there's an energy, a form of energy that can influence this particular, in vitro system without any other, placebo effect or, much less complicated, that's a start. That's a really important start that can then be moved into, say, an animal model and then later into a human. That's really starting at the basic side. And then at the more whole person side, there's a lot of things that happen during an energy, what we call energy Reiki, for example, that may have nothing to do with energy, that simply have to do with a presence, like a human presence, kindness, directed attention, that are more in the psychological, realm. And those are very interesting as well and very, very important. So I think the important thing is to look at this from both ends. And before some of the problems, I think, is that people assume that there's an energy, or by meaning electromagnetic energy component to this, that there's no proof of that. So it's a hypothesis. And so they need to be tested. And so the idea is, how do you test it?
Hopefully we will see that testing in the near future.
Hopefully.
Question about opioid prescribing. Have you seen the push for patient satisfaction surveys affect opioid prescribing and addiction?
Patient satisfaction.
So I know Jeff, and I think I know what he's getting at there, is he's an ER physician, and when your patient leaves the ER, for instance, and they have opioids or don't have opioids, it may change how they feel that they were satisfied by the provider. Like, did they get what they felt they needed because they were in pain?
Yeah. I think Dr. Chase knows more about this than I do. So yeah, I don't know any research on this. Maybe there is that I don't know about.
Yeah, I think that there's been a little bit of research on that. I'm not familiar with it myself, but that's a great question, Jeff. And I think it's something we should certainly keep in mind when we're talking about whole health, because we do want to know what we are measuring and why we are measuring it. And patient satisfaction surveys certainly have biases inherent to them. Next question. Any thought to incorporating the recreation services and park services to offer services and education to help with physical services like walking programs, et cetera?
Yeah, that's really important. And I think this is an area where we're really excited to be collaborating with other institutes at NIH. For example, the National Institutes of Nursing Research and Environmental Health, where we really want to start. Remember, I had that multi-level diagram where we can really start looking at systems level intervention at the level of communities, and like in parks. What's the effect of creating a green space? Or what's the effect of providing access to food? Those types of systemic level interactions. What effect does that have on individuals? So yeah, I mean, it's a very important part of health. If you can't get outside to exercise, it's really a detriment to the person. So yeah, the answer is we're definitely interested in those types of aspects of health. We're also interested in the effects of green spaces in terms of multisensory input. If you were to go for a walk in the forest, for example, there's a lot of things. It's called a multisensory experience. You hear sounds, you see, the beautiful, green color, etc. And it's very soothing. But also, there's certain volatile chemicals that are sort of released by plants that may play a role in the sort of sense of well-being that you experience when you're outdoors in a natural setting. These could be really important as well. So there's a lot that we can understand about the power of nature in helping people to feel better and be healthier. Mm-hmm.
No, I'm personally very interested in that as well. We've done some forest bathing on our weekly mindfulness experiences, and it's virtual forest bathing, but it still felt good to see something that I don't have access to
Isn't
readily.
it interesting, just this
yeah.
thought, because we all have obviously memories that we can tap into of being in a space like that. So being reminded, because that's a lot of things when you do a meditation or a mindfulness exercise and you go to a place in your memory, you can recall some of this. So, it has a lot of impact beyond, the time that you're fortunate enough to be actually in the forest.
Yes, absolutely. We have a couple of minutes left, but I don't see any more questions. So if you have questions, you go ahead and throw them in the chat. We can have time probably for one or two more questions. But in the meantime, did you have any additional maybe thoughts that have popped up as we've been discussing that you wanted to add?
Well, I feel like the important thing is to people to understand that we want to just continue to be a dialogue, and we always welcome people comments. We have some blogs at NCCIH that you can write comments to. We want to keep in touch. Obviously, once it's not only during the strategic planning process. We want people to stay engaged, and you can do this on Twitter. You can do this on our blogs, and so there's a lot of ways that you can stay involved and let us know what is it that you're interested in. So, yeah.
And I follow both you and NCCIH on Twitter, and it is very valuable. So I can endorse that. If you all aren't using Twitter for science, you should be using Twitter for science.
Yeah, sure. No, it's a great tool. It really, I like it too.
Excellent. Well, I think we are just about out of time. We just have like 30 seconds left here. So we'll go ahead and wrap up. Thank you so much, Dr. Landvan. That was wonderful. And we look forward to talking with you more on the panel.
Pleasure.
So next up, we have another break, and we will do a movement break again, a mindful movement break with Yal. So Yal, if you're ready, I will turn it over to you.
Thank you. Thank you so much to Dr. Langevin and also to Dr. Gigi for talking to us about the relationship between community health and social justice and how we could involve mindful movement. So I want to apologize also for shouting rat yoga into the chat. I meant to, that's actually a reference to Dr. Langevin's work on the relationship between the fascia and low back pain, but I meant to send that privately. So I'm going to go ahead and invite everyone. I got a request for hips and balance. So let's just work gently on that. I'm going to invite everybody to stand up. And just take your legs a little bit far apart, and you could keep a softness in your, actually, I'm seeing people wanting to shake a little bit. So just take a minute. Don't look at the screen. If you're lucky and you've got a plant around, we could, or a backyard, a tree outside, just maybe look at that. We'll get some almost forest therapy benefits from that. Ooh. And then find just a little back and forth on your feet. So I'm coming up onto the balls of my feet and then coming back onto the heels. I'm just going forward and back. I know my camera is not showing that. I apologize. Good. And then we'll just take the feet about hips width apart, and we'll just start drawing circles here with the hips. Keep your knees bent, and your hands could be on your hips, or you could just be loosey-goosey. Slow is the new strong. So I'm gonna go really slowly and just also notice if there's anything going on with my hips at any point as I'm kind of tracing the diameter of a circle. And we could go around in the opposite direction. Yeah, and I'm tracing the whole diameter, but if you notice, for example, that here there was a little bit of pain, you're welcome to just trace that part of the circle. So our movement really can be very, very easy, very accessible. I think that's the best way. right. And then I'm just going to bring my chair over so we can do this next thing. We're going to draw hip circles just one leg at a time. For balance, you might want to be by a chair, a wall, a piece of furniture, or you can test your balance by being away. Just depends on what feels comfortable to you. And I'm just going to lift up one leg and I'm going to draw again a really big circle here. I'm going very, very slowly, so I'm also engaging through all the muscles. A lot of time we think about stretching, but many of us also need stability and strength. Right, so either doing this, and in nature, everything is in spirals. So I think it's just another way that we could tell the story of our lives, the seasons of our lives is moving in circles. And if you've been going in one direction as I have, we'll go in the opposite direction. If you're trying to balance here, maybe gazing at something that's not moving, again, off screen is probably best. Good. And then just shake that out. And we'll go to the other side. So just nice, slow circles. If there's anything going on with your hip, you wouldn't necessarily do this full circle, but maybe you would even just do a much smaller circle. Testing balance or being really mindful. And it'll go around in the other direction. You could put as much movement into this or just be a little bit more still. And then we could shake it out. And if you've got a chair or piece of furniture, bookshelf, just maybe taking your hands on top and stepping back. So this is downward facing dog, little bit of a forward fold. And you could always rock a little bit here from side to side. You could bend one leg and then the other. You could keep your arms slack or keep them really straight. That's just a question of what would feel better for you this afternoon. Good. And you could also just come into a slight back bend, which was the rat yoga. So taking your hands right to your low back, lifting your sternum far away from your belly. If it's comfortable, you could look up, or you could take your chin to your chest. Taking a few deep breaths, like that belly breath. If you were here before, you got to see us do this. Good. And then we'll come on up, maybe just a few forward shoulder circles, just to move that spine in the opposite direction. And then we'll come into a stereotypical yoga pose called tree pose. So there's so many ways that you can practice this. Again, you can have a chair or piece of furniture nearby. I wish the camera on my laptop would let you see my feet. It doesn't, unfortunately. You can, we'll just stand on one leg, and with the opposite leg, you could either keep your toes on the ground, or you could start to slide your foot up the inner lower leg. You could pull it to the upper leg. But because we prepared by doing all those circles, it might even be fun to have your tree be even more spread out than normal. So maybe there's no connection between the heel and the thigh. And your hands again can be on the hips or out to the sides or up. And then notice how important your gaze is for your balance, right? The neuroocular reflex. And you're welcome to keep your gaze soft. Again, maybe on a plant that's in the room with you or something outside. Or you can even just close your eyes for a moment. Safer to do if you've got something nearby. And just check out how your balance is affected. And then we could just bring that leg forward, give it a little shake. And we'll come to the other side. So that's getting your balance again, maybe rocking from your right foot to your left, standing up and down. And then again, your choice on this side, what kind of tree you want to be. Hands on, hands off. See if you can make your face really soft. In fact, when I practice yoga, I usually imagine a moment that I had in the woods where I turned a corner and all of a sudden I saw a mother deer and her baby. And I just tried to make my body so soft that I wouldn't be a threat. And in that moment, they smelled me and made a noise and kept running off. Just making the body soft and relaxed, so much you wouldn't frighten a wild animal. Good. And then letting yourself come on down, just giving yourself one final shake. And returning.
Thank you so much. I needed that. I feel much better.
Thank you, Lee.
So next up, we are going to move to the panel, which I think is going to be very exciting if our talks were any bit of an intro, and I do think they were. So while everyone's getting ready, I've got a number of questions here that are kind of geared towards everyone. I've actually almost all of them, except for there's one for Dr. Jonas. So I think I will start with that one. If you are ready, Wayne.
I am. Let me unmute and
perfect.
Unpicture or whatever, non-picture, whatever you call it. There we go.
So the question is, do the whole person effects seen in post-COVID recovery open the allopathic medicine mindset to integrative treatments like acupuncture, mind-body, qigong, etc.? How do we make this important paradigm shift more mainstream?
Mm-hmm. Well, I don't think they automatically open it up because the first approach will be a reductionistic approach. Let's look at this organ and that type of thing, as Dr. Langevin mentioned. I think if we collect data on it and demonstrate that a more salutogenic modalities and combinations of those modalities are effective in improving long COVID and its recovery, then that'll wake people up, I think. So before COVID, so after COVID.
Great point. And if anybody else wants to speak on anything COVID related, I think now might be a good time for that as well. Or are we all COVIDed out?
COVID. Well, the only thing that I would add, can you guys hear me okay?
Yes.
Yeah, okay. I bet everybody in the room, Zoom room, noticed the media coverage this week about how, and I don't think we've talked about this today, how many healthcare providers are planning to leave the profession because they are just so burned out. And I think, I don't have an answer, I'm just putting this out to this community because I think that the numbers are pretty scary. I mean, the trend isn't surprising to me, but the numbers are pretty scary. And I think there's a role for integrative health, whole health, for all of us to play in addressing directly addressing this issue within our profession and being a part of the solution and perhaps helping people see there's a different way so they we won't have this mass exodus that's predicted right now. I don't know if other people have thoughts on that. I don't have solutions. It's been really resonating like, wow, we have to be a part of this.
Now this
is Gigi. As somebody who sort of lives and breathes this every day, I can tell you it's real. I mean, the amount, first of all, for anybody who's sort of an empath, you absorb everything. I mean, I will tell you that for my patients who are African-American, for example, and I've got about 55, 60% of my practice, I'll ask, have you lost anybody to COVID? 1 in 3 African-Americans have. How are you doing? You know, especially with the George Floyd trial, how are you handling the serial killings of Black people? How are you doing? You know, we absorb all of that, the amount of crying and mental health distress and phone calls asking us to help navigate people through the mental health system. That's real. And I'm certainly considering, I mean, I met with my Fidelity investment person because it's a lot and it's at a very high personal cost. So yeah, solutions, obviously are going to be multidisciplinary, but I think that acknowledging this and actually having it recognized on every single level becomes very important, because I can tell you that I'm certainly not alone.
No, that's absolutely right. I will just chime in on that. And also relating back to the first person's question, COVID has created huge opportunities because of the disruption. As I tried to illustrate in my talk, it's across the board, the disruption that has occurred in this area. And I think that those are opportunities. It's unfortunate that it has in crisis, but as you pointed out, Tracy, that's how opportunities emerge. The National Academy of Medicine is doing a series of studies, and we're co-sponsors on a couple of those on transformation of healthcare and healthcare. And we're supporting, as you are, Tracy, you've joined us, a financing study that is just launched. It's going. There's 3 workshops going to go on in May and June on how you create a financing system that actually creates health and well-being. That's the name of it, health financing for health and well-being. And I think this is an example of the kind of thing that will probably, hopefully, if it's picked up, take advantage of a truly transformative model. We're trying to make sure, as when we set up the questions for the National Academy, that they look at the issue of transformation in financing, not simply incremental components of how many treatments of acupuncture for this condition in that population, but truly how do you finance for health outcomes and disentangle it from particular modalities that really allow for creative integration of effective models, as Helene and others have mentioned. So I'll put that in the chat box, the links to that, and if people want to join it, it's open and free workshops.
That's great.
Thank you for sharing that. That sounds very promising.
I was going to say, I'm glad you mentioned the burnout, Tracy, and the toll that it's taking on the healthcare profession. I think we are just beginning to see that in its full. I mean, we haven't obviously gotten the chronic impact. The acute impact has been, I mean, tremendous in terms of the frontline workers and all that, but the chronic impact is going to really be difficult. I think the whole post-acute syndrome is going to be so important for us to really get our heads around that and understand it, and also apply it to other situations. I think that we are not very well understanding these post-viral syndromes, these post-stress syndromes, these like the Gulf War illnesses, all of those things, chronic Lyme, these illnesses that are very complex and that has to do with, I think, lack of health restoration. And so hopefully we can get some insights from this very large wave of post-COVID that we're going to have to study this in a way that it can be effective and can then illuminate our understanding of a lot of other chronic conditions. So let's hope anyway that we get some answers.
And I guess I will also throw in that since I brought that forward, which is kind of heavy and depressing, I think the interesting parallel is if this data is still current, that the very big increase in kids, I'll call them kids because I'm getting so old, the applicants to medical school, and the huge rise in COVID and in COVID times. And I think, I make up an interpretation of that, and it's just a hypothesis, but I look at that and go, okay, who in this environment of this epidemic or pandemic would be called to go into the profession in such greater numbers than previously, right? Because for years it's been, on the down slope. So what is that about? I find that really encouraging, because I conclude those are not people who are going to be drawn into the profession because they want to, be the next great, neurosurgeon. I mean, these are people, I'm assuming, based on the suffering of the epidemic and the pandemic, is that these are people who are drawn to the humanistic side of healthcare. And that to me feels very encouraging, that we have potentially a whole wave of a new generation who are being drawn into this profession for holistic, humanistic reasons. And that could be very, very important as we move forward.
Yes, and very refreshing. That's what we need. So I like that positive outlook there. We have to be positive, at least in some way. So actually related to that, this question is from Ethan. With the cost of healthcare and poor insurance coverage or lack thereof being a huge barrier for millions of Americans, how does this whole health approach, and specifically the transition from reactive to proactive care, factor into the care for our low-income and underserved communities who oftentimes are hesitant to seek care until it's too late, per se?
Did you want me to take that? I'd be happy to.
Absolutely.
Sure. So just to again remind you, if it were a matter of people being insured, DC would be actually the second healthiest in the country. Massachusetts is the only other place that has more coverage. 97% of DC residents actually have insurance. And that's been, it's not been that high all the time, but that's been true that DC people have been well insured. So really it's about poverty. It's about the economic health of the neighborhoods where people live and go to school and work and all that kind of thing. So if I had a magic wand to look at improving people's health, I would make sure that there is more income equity. I would start there, educational equity. I'd invest in making sure that babies and children get the right start. But I would be looking at much more in the way of economic development and really trying to leverage that. Then, I mean, yes, health systems, of course, I'm a doctor, I'm going to say, yes, that's important. And we do have problems within the health system. Here, for example, in DC, we've got Medicaid. And so theoretically, people can get an oncology appointment, but actually there are only 3 oncologists in the city that take Medicaid. There are more people listed, and actually I'm very proud to say that GW, now has rejoined, because there are problems with the bills getting paid by DC government, in terms of chemo and all that. But so things can look theoretically fine, but the implementation of it, and that's where I think over and over and over again, the theme is going to be science implementation. What does that really look like? From the theoretical to what's happening, and really addressing the barriers there.
If I can just add to that, I think the question really of being proactive is key, and I want to point to something Tracy must have mentioned 3 or 4 times, which was the peer delivery system, the peer partners. This is really the way to do it, peer support to do it. It's worked in the NIH, it works in underserved communities. It is an army of individuals that know the community, that reach out into the community and do that kind of proactive care. There's been randomized control trials of it. There's been, from childhood on up, showing it's highly effective in shifting this the underlying determinants of health. Now, that said, you have to have resources to make sure people get what everybody knows is needed to flourish, right? The basic triangle of Maslow's hierarchy has to be there, or they can't tap into that. But as she also pointed out, if you empower people to do it, they are very, very creative about getting through whatever circumstances they have. So I think the core model of a future healthcare system for whole person care, integrative care, should be anchored in this kind of peer or health partner model.
Took the words out of my mouth, Wayne.
Right, and this whole empowering of the individual, of the family, of the community, so important, that people can take charge, and of course need support for that. And I totally agree that the peer support at that level is key, and making sure that the patient is fully supported, so that then they can take the lead in their own lives. So good.
Absolutely. And branching off of that, how do you get them to take the lead? This question specifically, how do you engage patients in determining their purpose or meaning? They seem to struggle with this concept.
Well, I can try to answer that, just because, and I'm not the expert on my team that's doing this, but the experience with developing this model, first in the VA and now continuing that work, is, and again, this is borne out by the research, like Wayne was saying, the key characteristic for an effective peer leader is essentially, put in simple terms, that they're people, right? That they're good with people, and they're good, like, connecting and communicating. And the less they are of the clinical world, the better, right? Because we're trained to give, assessments and plans, and a peer reaching a peer is about connecting on a human level. So, what we've done in the VA has developed an educational program, first having potential whole health partners first have the experience themselves. And then, of course, what happens, like those quotes I shared, is when somebody's life has changed because of this, they want to do this and want to reach out to other people. So we have a training, and if you have folks who are actually in the Whole Health Institute offering kind of another a version that's not totally focused just on veterans, of course, and are offering those trainings free of charge. We have to scale up, but please let us know if you have populations of people that would like to have the experience of. We have a 9-week program. It's called Taking Charge of My Life and Health, designed to do that. And it's been, studying and is really effective. And then we also have facilitator training for peers who want to then be trained to offer that. And so I do think there's a methodology that's effective. And yeah, it's going to take a lot to scale it. But I do look at things like other movements, other grassroots movements. And when one person says to another, hey, and I'm telling you, like, it's as simple. And I don't know why this woman comes to my mind, but there was a woman who said, my purpose is, and I'm just sharing some examples because it doesn't have to be, I often tell this Mount Kilimanjaro story because it's a fabulous story to illustrate this, but then it makes it sound so aspirational, like, oh, you have to have a mission, like, a purpose to climb Mount Kilimanjaro. Well, this woman's mission and purpose was she wanted to ride in a roller coaster with her grandson. And she was too fat, in her own words, to fit into the roller coaster. So, I mean, and she's like, I want to do this. I need to do this. I mean, she was impassioned about it. And guess what, right? So suddenly she starts to lose the weight. And so I think that it doesn't necessarily have to be kind of a spiritual quest of purpose. It's whatever that is for that person. So I don't know if that helps explain that a little bit more, but it's really amazing to watch it unfold. It really is magical.
So I'm going to take a contrary point of view, because although these examples are fine, I think that in some way we have to be careful not to blame the victim. And this is what I mean. Back in the 90s, during the AIDS pandemic, my mother, who's a medical anthropologist, and I actually wrote an introduction to the Black Anthropology Journal's edition on AIDS. And at that time, some of the researchers, and one researcher in particular, was looking at why was it that Black male young men did not use condoms? And so if you think about it, actually they were doing risk assessments. There was so much gun violence that they decided that for their risk, there was making it to age 25 was so low in terms of probability to them that it wasn't really worth using the condoms. So sort of when one talks, and as I say, this pandemic has just brought so many issues to the fore about the competing priorities, which I think is so important that we collectively, understand that competing priorities also drive behavior. I don't know about you, but when I've got a million things to do and I'm under deadline, right? Got to write my notes and everything else, then there are things that start to slip, right? And so I appreciate what's being said about peer sort of motivation, and that's important. But I would also add that community-based organizations, so in Ward 8 there and in Ward 7, there are a total of 10 family success centers. So the people that work in these community-based organizations and serve the people are the people that know them best. And it's not necessarily community health worker in the usual sense. It's actually, in a way, they have all of the resources that they that they know about sort of everything, including the governmental resources that are available. So they have a double role, being within a sort of larger system, knowing the community, working with the community, within the community, advocating, but also following up. And it's a little bit more structured, if you will. And that's actually the model that we use to get people vaccinated. So we did the train the trainers, education, about 7 90-minute sessions, so that, believe it or not, we used Johnson & Johnson for the vaccine. And I was actually very nervous because it was like 6 days later that they did the pause, that people were going to be upset or were going to call. But we had done so much work collectively, they had done so much work collectively, that there wasn't actually any kind of, a few people said, they were concerned about the vaccine, but the people that are working there could then answer questions in real time. And there was that trust element. So I don't think it's an either or. I think it's this and that both. But from a physician standpoint, we are very judgmental. We really are. And we don't always appreciate these competing priorities.
Correct. It's an excellent point. I think that it's more than health, isn't it? Where is health on the priority list of the person you're talking to? And very often it's low, unless it's connected to their life purpose in some way. If I was going to use a word, it's the development of trust. There's a wonderful model. I visited their clinic several times. They're now spreading around the country. It's called the IORA model. It's also very similar to something up in Alaska. The Southwest Central Foundation runs a whole health system for Alaska Natives called the NUCA model. And it's based on creating community input and really community delivery, but then having to connect it to the healthcare system. That's where the challenge is, right? So a community service worker may not know anything about the healthcare component, and the healthcare may not know anything about the community itself. And that's that intersection, I think, that that you know, I think can enhance and make better health outcomes in those areas. And if there was a single word that comes out of both of those models, IORA and South Central Foundation, it's trust. I mean, where they really do trust or distrust, you know, who they're working with and interacting with, and that allows for that bridge to be built. You know, in anything. Tracy, I noticed at the end of your video, the fellow's looking out in the ocean and he says, you know, what do people live for? That was the question at the bottom, right? What do people live for? He didn't answer the question.
That's right.
He didn't answer the question, but every one of them was holding up something, a picture or something like that, of something that meant a lot to them, usually something they loved. So you got to put love in there somewhere, right?
Absolutely. Absolutely. No, thanks, Wayne. I think that's absolutely right. And I think, Gigi, your example of how you train the trainer around the vaccine in the communities is exactly an example of what we're talking about. Training peers to reach people in their communities and changing the conversation, like we talked about, to not be about, you know, what's your hemoglobin A1C or your blood pressure, when somebody's just trying to get through the day. I mean, that's exactly the very essence of what we're trying to shift, which is kind of the antithesis of blaming the victim, I think.
Yes, yes. I didn't mean to, please forgive me. I didn't mean to imply that by any means. I'm just adding something. So forgive me if I came off that way.
No, it's good. It's like you said, it's both and. There's a lot of solutions that are needed.
Well, hello, everyone. I am back. I'm not sure what I missed. Unfortunately, my internet is out, so now I'm on my phone. But I'm glad I'm still here to join you because I know this conversation is fantastic. Are we done talking about this topic and want to move on to another question, or is there still more to talk about?
We're good.
Okay, excellent. So the next question is, where do you see the clinical lab fitting into this model? Patients are now able to order their own lab tests in many cases. How can this be incorporated into the model of whole health?
This is such an interesting question, I think. The whole amount of information that we're now getting from our mobile devices, you know, all the things, all the health information that people are getting, and it's not being integrated, right? And a great example of this is what's going on right now with the point of care COVID testing. You know, all these tests, that results that we get statistics on every day, you know, so many people tested. That does not include these new point of care devices and these new devices that people can now get in their homes to do their own COVID testing. And so this is a whole new aspect of health that we're going to have to wrap our heads around. How is all of that going to get integrated into some kind of coherent strategy so that all this information is kind of synthesized, right? It's the new frontier, I think, of healthcare, which we really don't know right now. Is that going to be how it'll be helpful in the end, but what are going to be the bumps in the road? There will be some ways in which it will not be helpful, for sure. And how can we be proactive in making sure that all of this information that people get, it does not get kind of used in ways that are not useful. It's very tricky, I think.
I agree with you, Aline. I mean, this is there will, as any new technologies produce, there'll be pros and cons to it. Yeah. I mean, too much information can result in too much treatment that can damage people, you know, can hurt you. You know, on the other hand, when Apple comes out with its new a glucose monitor watch that allows me to simply push a button and see my glucose after I eat that brown rice and see if it really does control my blood sugar. I'm not even diabetic, but I'm gonna get that watch, and that'll motivate me to buy one because I'll want to see what is my day-to-day activity doing to that very crucial health parameter, right? And there'll be a hope I'll probably be overloaded in information that's irrelevant to me. But I'll still be interested in it, and it might empower me in terms of saying, hey, now I know that if I eat the banana, it's not good, but I can have an apple because of, who knows, my microbiome or something like this.
Yeah. But you hope also that you have the psychological structure to not incorporate this and turn it into anxiety.
You bet.
Which, you look at people who become afraid to eat because of food sensitivities, and there's a lot of that I think needs to be managed really well. And sometimes I think it's kind of, people will start doing their own thing, and it can really be psychologically taxing, I think, for a lot of people.
And the market will exploit that. The market will exploit that, and they're always way ahead of the science. And so, that's the risk. So
yeah. Don't want to be too pessimistic, though.
Well,
there is some good to be.
But it's amazing. I mean, to put some of your health parameters in the palm of your hands. Talk about empowering for if it's properly framed.
Absolutely. Oh yeah, yeah. We'll have to learn how to use it.
We sure will.
So I just want to let you know that the GWMLS program had a CE conversation about this. You all might want to talk with them. It'd be a great collaborative experience for everyone involved.
Great. Well, thank you. I just want to wrap things up a little bit. We are running out of time, and I was hoping we could each give one last final point, maybe what you see as being the most important next step to moving the whole health revolution forward. We can go in order. Dr. Jonas, you want to go first?
Let's see. While I was, what's the most important next step? I would say a mindset change. I would say people have to begin to see, it's what I said in the beginning of my talk, that on Monday, you'll begin to perceive people differently, and you'll begin to interact with them and dialogue and talk with them differently. To see them for all the dimensions of human beings, even down to the center, the mental and the spiritual, the sacred component. And I think if we can hold each other in that kind of sacred space and listen to them in that sacred space, our healthcare, no matter what modality we're using or interaction we're using, is going to get better. And so I think making that mindset change, to me, is the number one most important thing.
Thank you. Dr. Gaudette?
Well, I totally agree with Wayne, as is often the case. And so coming at it from another angle, I would say working together in collaboration in unprecedented ways. I think we're all extraordinarily collaborative in nature, but I think those of us working in healthcare, compared to health sector finance and policy, education, communities, workforce, et cetera, need to come together in truly unprecedented ways to say, what happens if we dance together? What happens if we integrate and align our transformational efforts? And can we collectively take it to the next level?
Excellent. Dr. El-Bayoumi?
Yeah, I would say changing the locus of power. The locus of power has to be, and then again, this is difficult for us in the healthcare system, has to be with the community. It's not, the people who are closest to the problem know the solutions the best. They may not have the resources. So I always see our role as being consultants, but really supporting what their vision of health and wellness is.
Absolutely. Participatory care. I love that. And last but not least, Dr. Langevin.
Well, I feel like this was a multiple questions, all of the above, mindset change the locus of power, and collaborate. Wow. I think if we can do those three things, I think it'll really move the needle. I would say we really need a transformation. And, you know, transformation is sometimes, you know, it's hard, and but once it gets going and once it becomes apparent, it can quickly gather momentum. So I would say that I really like those 3 ingredients. I think they could really set something going and really transform our approach to healthcare. I really do.
Excellent. I hope we started some of that today by bringing everyone together to have this conversation. So I want to thank all of you so much for joining us. I'm sorry I am not in front of you anymore because I'm on my phone, but I really appreciated all the information you provided us. The conversation was fantastic in the panel, and I can't wait to see what comes from all the work that you're doing. So those of you who are looking for continuing education credit from this event, please email Janet Rodriguez at gwu.edu. She would be the one who was sending you emails prior to this, so that's how you can find her. Also, please follow us on social media, and you can find our website at OIMH. So if you just Google OIMH, we are the only OIMH on the internet. We also have a newsletter and a podcast wherever you get your podcast, GW Integrative Medicine. So with that, I will adjourn, unless, of course, Janet has something she'd like to add.
No, just thank you for joining us, everyone. We appreciate you. Have a beautiful weekend.
Thank you, everybody.
Thank you.
Bye.